Good evening, everyone, and welcome to Secrets Unveiled PACES. Thank you for joining today's session. This course is designed exclusively for the long clinical consultation of MRCP PACES exam. Our aim is not just to teach you what questions to ask, but how to think like an examiner and approach every long clinical consultation in a structured, confident, and logical way. So this course is going to be a little bit interactive. If anytime anyone have any kind of confusion, please feel free to ask me at any time. So actually many candidates already because there are hundreds of possible cases in PACES exam. But the good news is that the numbers of prompts is actually limited. Once you master the prompts, you can confidently approach almost any long clinical consultation case. And that's why I personally believe what eyes cannot see, uh, actually, what eyes cannot see, what mind does not know. If your mind knows what to look for, your history taking becomes focused, your examination becomes meaningful, and your differential diagnosis become much easier. Today, we will begin by learning the foundation of LCC history taking, and our first session will be first introduction to the history taking. Then we will discuss how to take history for each and every musculoskeletal prompts coming in the PACES exam. I hope this session will be first step towards your PACES success. So let's begin our journey together. So let me first discuss what is the structure of PACES exam. There are actually 5 stations at the PACES exams. There are station 2, station 1, station 2, station 3, station 4, and station 5. At station 2 and station 5, there are long clinical consultation. And truly speaking, these stations are the most important, and the candidates face the most difficulty for these 2 stations. The good news is that this course is going to prepare you almost all the things that you need for passing this exam and for passing and getting full marks in these 2 stations. So to make it easier, the course is actually runs by uh, first prompt session, then homework materials, then practice session. Excuse me. So let me tell you first what is prompt. May I know if my voice is clear to all? Is it audible?
Yes,
But
audible.
okay. So prompt is actually the given symptoms that for which we have to take history at the PACES exam, like joint pain, chest pain, abdominal pain, swallowing difficulty, and palpitation. What happens at the PACES exam? At station 2 and station 5, right before entering the room, you will be given a scenario with a written page that this patient has come with swallowing difficulty. You will be given the name like Mr. Jackson, 45 years old, has come with swallowing difficulty. We will be given with certain vitals of that gentleman, and the instruction will be talk to the patient, examine him, and meet his concern. Something like this. This is the case note. The prompt will you will face in the PACES exam exactly like this. This is the written scenario exactly given in the PACES exam prompt. This is from the PDF case notes. Another example of prompt is this. So these are actually the prompts that hand ping. And there are actually lots of prompts in real life. But if you notice the pattern of PACES exam, actually there are actually 73 prompts. I have identified them. I have identified them for the last 4 years. And in this course, we are going to learn them step by step. So the prompts are divided according to each system, like the neurology, gastroenterology, musculoskeletal system, cardiology, respiratory system, renal, endocrine, dermatology, and miscellaneous. Again, the prompts are divided based on the importance, like today's session. We are going to discuss later by on. Just a second, there's sounds coming. I'm taking a pause and I'm coming back again. Sorry, doctors. Actually, there was lots of sound coming. That's why I took the pause, and pardon for that. So let's come back again. I would like to discuss once again. So actually, the prompts are the given symptoms for which we have to take exam at the PACES exam. In real life, there are lots of prompts. But if you look at the pattern of PACES exam, actually the prompts are limited. So what I have done personally for the last 4 years, I have identified the possible prompts coming in the PACES exam. And the prompts are divided actually based on the systems like the neurology, gastroenterology, musculoskeletal system, cardiology, respiratory, and so on. Not only that, under each system, the prompts are again categorized based on the importance, like this one. Today, we are going to discuss the approach to these prompts. So actually, once you understand how to take history for hand pain, then you can just face any type of case come with hand pain. If you know how to take history for low back pain, what differential diagnosis you have to think for that, then it will become very much easy for low back pain, what type of case you face in the PACES exam. So in spite of doing blind approach, we in this course, we first learn how to take history for each given prompt. Because eyes cannot see what mind does not know. Once you understand how to take history, then it will become easier for you to perform. So may I know, up to now, is there any question from any of the candidates? If you have any kind of question, you can feel free to ask me anytime. Okay. So what is long clinical consultation? What we have to do? Right after entering the station, we will see two examiners there. One of the examiner will greet us to enter the station. Yeah, Dr. Tejas has asked a question. Okay, doctor, actually, the systemic prompts are discussed one by one at each prompt session. Like today, we are going to discuss the musculoskeletal system prompts. Yes, doctor?
Yes, sir. Yes, sir.
Okay. So it is discussed at each session separately. Right now, we are going to discuss only the musculoskeletal system prompts. But before that, I will give you a written format how to take history effectively and wonderfully. Because PACES exam is 50% acting. You have to know how to act properly. You will get it once you go through the slide. So this is the flowchart for which we have to perform in the PACES exam. Right after entering, we have to do a good introduction. For introduction, what line you have to mention, you will get it in this slide. Then we have to do the symptom analysis. How to do the symptom analysis? Again, I will discuss one by one. Then we have to do the systemic review. Then we have to take the history in the form of PDF, Sajid, PET, and 5P. Don't worry, I will discuss each of them separately. Then we have to examine the patient and we have to meet the concern. Based on our whole performance at these 6 steps, we will be given mark in these mark sheets. So when you will enter the exam, you will see that 2 examiners are carrying the mark sheets at their hand, and there will be 2 separate mark sheets for each of them. There are total 28 marks for this station, and each examiner can provide you at best 14 marks. And these 14 marks are assessed based on your performance at these 7 skills. So now you can guess the highest skill for each of the highest mark for each of the skill is at best 2. If you perform satisfactorily, you will get 2. If you don't perform satisfactorily, it is borderline, you will get 1. But if it is unsatisfactory, then it is 0. And the examiner will write in details why he has given 0 to you. So in this course, actually, we don't perform. I like to make every candidate as an active mentor. In the homework, right after completing the homework of taking the detailed case notes, you have to start performing one with other. And you have to practice providing the mark sheet with each other. That's why this session is going to be very much important. You have to know how the skills adjust. So let's start with physical examination first. So in the physical examination, what things are assessed? Before starting for physical examination, I want to tell you something important. There are two ways of doing physical examination. One is starting with general examination, like checking the hand, looking for pallor, then checking the eye, looking for anemia, jaundice, then checking inside the tongue, doing some auscultation, checking a wafer to check the blood pressure. These are the conventional way. This is wonderful. But in this course, I try to teach the students, the candidates, some different techniques. The name of the technique is Triple CA. What is Triple CA? From now on, it is going to be interactive. Triple CA means we have to do the physical examination to confirm the diagnosis. Then we have to do the physical examination to find out the cause, or in some case, we have to find out the trigger. Then we have to rule out the complication and we have to look for association. One of the doctor is complaining of network issue. Is there any issue with hearing to the doctors? May I know? Okay. I think it is clear to all, so we can proceed on. So in the physical examination, to gain satisfactory, my suggestion is go for triple CA. So what is triple CA? We have to physical examination to confirm the diagnosis, then to find out the cause, then to rule out the complication, and looking for association. Not only that, this triple CA has to be looked for not only in the physical examination, but also in the history and investigations. Let me give you one example. There is a popular prompt in the PACES exam. The prompt is swallowing difficulty. So in the PACES exam, suppose you have been given a case of 35-year-old female has come with swallowing difficulty. And the definition and the given diagnosis is myasthenia gravis. In myasthenia gravis, actually oropharyngeal dysphagia happens. We are going to discuss in detail how to approach for dysphagia in our next prompt session in the GIT prompt. So oropharyngeal dysphagia means it is one type of neurological dysphagia. Here dysphagia happens right before start of swallowing, and there is nasal regurgitation, voice change, all the things are there. So we have to first, from the history, we have to confirm the oropharyngeal dysphagia. Then we have to find out the cause. Then we have to look for the complication. At last, we have to look for association. So how to confirm our diagnosis from the history for oropharyngeal dysphagia? We just have to ask, may I know when your swallowing difficulty starts? Is it at the beginning or after the start? Is it at the before? Is it before the swallowing, or is it after you start the swallowing? If the patient complains of it starts before the swallowing happens, then it is oropharyngeal dysphagia. Then the underlying cause is myasthenia gravis. So we have to use one screening question for this myasthenia gravis. And the screening question is, do you feel fatigue at the end of the day? Then from the history, we have to look for complication of this oropharyngeal dysphagia. Can anyone guess what can be the complication of oropharyngeal dysphagia? Any doctor? Any volunteer?
Candidiasis.
Sorry?
Aspiration pneumonia.
Yes, doctor, aspiration pneumonia. So we have to rule out the aspiration pneumonia from the history. How we can rule out? We just have to ask, do you have any cough with film? That is history of productive cough. Just by asking this question, the examiner would understand that this candidate knows how to rule out what can be the complication of any type of dysphagia and how we can rule it out. Truly speaking, I can make you 100% guarantee. In the PACES exam, you will never ever get any aspiration pneumonia due to myasthenia gravis. But in front of the examiner, we have to do this acting to rule out the complication first from the history, then from the physical examination, then in the investigation. That's why I have told that this is 50% acting, and you have to know for which role you have to do the acting. There is another complication of myasthenia gravis. Can anyone mention it?
Respiratory failure?
Yes, respiratory failure. So for this, we have to ask, do you have any breathlessness? And that's all from the history that confirm cause and complication. Now the association is left. Myasthenia gravis is an autoimmune disease. So for any autoimmune disease, we have to rule out other autoimmune association. There is a wonderful mnemonic for that. The mnemonic is DAT CPR MV. Here D goes for diabetes, A goes for Addison's, T goes for thyroid, C goes for celiac disease, P goes for pernicious anemia, R goes for rheumatoid arthritis, M goes for myasthenia gravis, and V goes for vitiligo. In this course, you will get a lot of mnemonic to remember the mnemonics, to remember the prompts and many other things. So you have to make a lot of notes for that. So how to rule out diabetes from the history? Can anyone tell what is the screening question or presenting feature of symptomatic diarrhea?
Polyuria?
Yes. So
Polydipsia?
polyuria, polydipsia is a jargon. We have to ask.
Oh, sorry.
Yeah, you're right, doctor. You know what to ask. Now you have to know how to ask. How can we ask for polydipsia? We can ask, whatever to thirst, any excessive thirst. The polyuria, we have to ask, what about your urine output? Many doctors will prefer to use the term water output. But from my experience, at the Indian centers, the surrogate actually don't understand what is water output. They prefer the term urine output. So we have to use the screening question from the history to rule out the diabetes. Then to rule out the Addison's, we will use the screening question of postural hypertension. That is, do you feel dizzy standing from the sitting position? To rule out the thyroid, we have to ask, do you have any weather preference? Then to rule out the celiac disease, we have to ask, any loose motion related to bread, pasta, barley. We can use this one line to rule out celiac disease. You will never ever get celiac disease with myasthenia gravis in the PACES exam. But just by uttering this line, you are giving an indirect information to the examiner that you know celiac disease can happen with myasthenia gravis, and you are ruling it out because you are a safe doctor. Then for pernicious anemia, we have to ask the questions of anemia. That is, do you think you are getting pale day by day? Then for rheumatoid arthritis, you have to ask, do you have any joint pain? The case is itself myasthenia gravis. For vitiligo, sometimes you can get vitiligo with myasthenia gravis in the PACES exam. So if you find hello, is there any sound? Okay. So to rule out the vitiligo, you have to look at the patient, whether you can identify any hypopigmented skin rash. If you don't get it, don't worry. You have to tell to the examiner that I want to do full skin survey to rule out any hypopigmented skin rash, that is vitiligo. If you do say the line in such way, in this way, you can rule out all the triple C A from the history. So the history part is complete for triple CA. Now we will progress to the physical examination, how to rule out the triple CA. But up to this point, may I know if anyone has any kind of question? If there is no question, please give a thumbs up reaction so that I understand that it's clear to all. Because every time I try to do some interaction, and at middle point, I will ask you some question. I will give you some scenario, real PACES scenario, to make the scenario session more interaction. Then come to the physical examination. How to rule out the triple CA. Another thing for triple CA is you will not find all the components of triple CA for all the case, but you have to look for that. So for this oropharyngeal dysphagia, that is for myasthenia gravis, what do you think? How can you confirm the diagnosis? Any doctor? How can you confirm the oropharyngeal dysphagia from the physical examination? Any idea? Any volunteer? Will you offer to swallow liquid to the patient to confirm it, to see whether the patient has aspiration or whether the patient has some nasal regurgitation? No.
No.
Yes, because if you offer to swallow liquid, that will clearly affect your welfare mark. So for that, this case, we don't have to do any examination to confirm the oropharyngeal dysphagia. Now to find out the cause of this oropharyngeal dysphagia, we know that the underlying cause is myasthenia gravis. So now we have to follow the sequences of examination of myasthenia gravis. What are the sequences? In this course, you will get a detailed recording of the steps of examination of myasthenia gravis. So this is accessible to all the registered candidate. You will get it for some physical examination with this format, and for something you will get it in the physical examination recording directly from myself. So this is the examination sequences of myasthenia gravis. First, we have to start with ceiling test. How to do the ceiling test? We have to tell the patient, look at the ceiling, raise your arm, and count from 1 to 30. And gradually, you will see that the patient's arm is going to drooping down, his eyes is going to be more droopy, and his voice is going to be changed. So this is the screening examination for any type of myasthenia gravis. Right after screening, we have to do the rest of the examination. These things are explained in details in the physical examination recordings that the type 1 and type 2 candidates will get enrolled, will get access. So we have to check the weakness of the facial muscle, then we have to check the edge movement, then we have to tell the patient to give a smile, blow a whistle, and the important part is we have to tell the patient to open the mouth and say ah. By mentioning the patient to open the mouth and say ah, we are checking for any bulbar weakness. So this thing is discussed in later detail on, but this is the examination to confirm the diagnosis. Sorry, to find out the cause. Pardon for my mistake. This was the examination sequences to find out the cause. Now, what can be the examination to find out the complications? Can anyone tell me? Any volunteer doctors? What examination can we do to
Chest
find out the
X-ray, aspiration.
it's the
Lung
yes,
auscultation.
yes, lung auscultation. Chest X-ray is in the investigation. We have to do the lung auscultation. This is just an acting. You can take it as a guarantee. You will never ever find any evidence of aspiration pneumonia for a patient with myasthenia gravis in the PACES exam. But whenever you are doing the auscultation, you are giving an information to the examiner that you know aspiration pneumonia can happen due to this dysphagia. So this is the examination to find out the complication. And for any type of myasthenia gravis, this line is a must. That is, I want to complete my examination by doing bedside force vital capacity, because this is the most grievous complications indicating myasthenia crisis. Then to rule out the association, in the form of dead CPR-MV, we can do some physical examination. In diabetes, there can be high blood sugar. In Addison's, there can be postural drop, that is postural hypertension, also hypoglycemia. One of the gravest complications of Addison's disease is hypoglycemia. So to rule out the diabetes and Addison's disease, we can just offer to check bedside blood sugar and sitting and standing blood pressure. Then to rule out thyroid, we have to check for goiter. We just have to tell the patient, can you take a sip of water? Then after kneeling down at the patient's neck level, we have to tell the patient to swallow the liquid. In the PACES exam, you will never ever find any goiter associated with myasthenia gravis. Even after that, we have to offer to do this examination. We are giving an information to the examiner that we are ruling out thyroid association for this case. Then for celiac disease, no examination is required. To rule out the pernicious anemia, we have to check for conjunctival pallor and glossitis at tongue. Then to rule out the rheumatoid arthritis, if there is no history of joint pain, then we don't have to examine the joint in the physical examination. The case is itself myasthenia gravis. For vitiligo, we have to offer to complete our examination by doing full skin survey, looking for any hypopigmented skin rash. And that is the way we can complete the CCCA and gain the full mark in this physical examination skill. May I know, is it clear to all? What is the conception of CCCA from physical examination? It is very much important to understand, because right after this session, musculoskeletal session, you will be given 33 cases from the musculoskeletal prompt. These are actually real PACES case. And you have to practice how to format this CCCA for the physical examination during your homework and mutual practice. You'll be given guidance for that. So before proceeding on, may I know, is it clear to all about the physical examination skill? How you can gain it full mark by doing the CCCA? Any confusion from any of the doctors? If it is clear, please give me a thumbs up reaction so that I can proceed forward. Dr. Priya is clear. Dr. Nusrat, do you have any confusion?
No, no
I want to
confusion.
ask, I
Sure,
want to
sure.
ask when to ask triple CA after symptom analysis or after social questioning.
I'm discussing regarding the history part later on, during
Okay.
the clinical communication skill. That is
Okay.
a lot of thing, and actually this course is mainly focused on that skill. But I'm going to discuss one by one based on the skill first. So please let me know whether you have any kind of confusion regarding the physical examination skill right now. Then again, let me complete the investigation for this CCCA. Like, the patient is having swallowing difficulty. That is oropharyngeal dysphagia. So how we can formulate the investigation in the form of CCCA for this patient? For any type of swallowing difficulty, to confirm the diagnosis, first we have to mention apart from basic investigation. Believe me, this is the most simple thing and the most things that is done unintentional mistake for the PACES candidate. They forget to mention apart from basic investigation. In this whole course period, I'm going to show you some real feedback where you will see that the candidate mentioned all the other investigations, but failed to mention the basic investigations. So from now time onwards, up to the next 2 months, you have to practice this thing that regarding investigation, you have to start answering by mentioning apart from basic investigations. So apart from basic investigations, to confirm the oropharyngeal dysphagia, the investigation of choice is video fluoroscopy. It is actually video fluoroscopic barium study. So to confirm the oropharyngeal dysphagia, there are multiple causes of oropharyngeal dysphagia. This can be due to stroke. This can be due to motor neuron disease. This can be due to myasthenia gravis. In the PACES exam, only the myasthenia gravis comes. So to confirm the diagnosis of oropharyngeal dysphagia, the investigation of choice is video fluoroscopy. Then to find out the cause, you have to do these investigations. Some antibody test in the form of anti-acetylcholine antibody. If it is negative, an anti-mask antibody. Then we can do some electrophysiology in the form of repetitive nerve stimulation test and single fiber electromyography. Then we have to do some imaging like CT scan or MRI of the chest, looking for thymoma. Then to find out the complication, we have to do chest X-ray. One of the doctor have already mentioned. So this is the investigation to rule out the complication. Then look for association. We have to do fasting blood sugar and HbA1c for diabetes. For Addison's, we have to do 9 AM serum cortisol. To rule out thyroid, we have to do the thyroid function test. For celiac disease, we have to do celiac serology. For pernicious anemia, we have to do CBC with peripheral blood film, with serum vitamin B12, with red cell folate, along with antiparietal cell antibody. And rheumatoid arthritis, if there is history in the if there is history of joint pain, then we have to order rheumatoid factor with anti-CCP. Otherwise, it is not needed. And vitiligo is a clinical diagnosis. No investigation is required for vitiligo. And that's all for this triple CA from the investigation. In this way, we have completed the triple CA conception from the history, from the physical examination, and from the investigation. So if you can present your case like this, whenever the examiner is going to ask you what are the investigation you want to do for this case, then if you can give your answer in this organized way, it will really create a good impression. In this whole course, you will get this in recorded form. And you have to make these notes over the PDF case sheets that you have got. You will see that right after each case, there are 3 to 4 blank pages. So you have to take the notes from these blank pages, at these blank pages, from the recordings that you will be given access. So may I know, up to now, is it clear about the conception of triple CA to all the doctors? Any confusion from any of the doctors? Dr. Amit, do you have any confusion, doctor? Dr. Tejas, actually, the recording will be for the registered doctor. Dr. Amit, can you hear me?
Hello.
Yeah. Do you have any confusion, doctor?
Actually, I have joined a little bit late. I have missed some part of myasthenia gravis beginning part. I'm trying to understand.
Okay, you can cover it from the recording.
Okay, thank you.
Okay, most welcome. Dr. Kashif Gulzar, may I know, doctor, do you have any confusion? Dr. Kashif, can you hear me, doctor? Okay, I think there's no. Dr. Farjana, Dr. Maya, any confusion from your side? Am I audible?
Hello,
No
sir. I have a
confusion. Thank you.
Okay. Dr. Akanksha, any confusion from your side?
No, sir.
Oh, yes. Okay. Dr. Probir, have you got the point, doctor?
Yes, I got the point. No confusion so far.
Okay. Please feel free to ask me anytime during the prompt session.
Okay.
if you have any confusion. Don't
Sir, I
hesitate to
have a
stop me.
question, sir.
Sure. Please proceed on.
Sir, in investigation part, should we say spirometry to exclude the respiratory failure, one of the complication of myasthenia gravis?
Yes, good thing, doctor. You can add this. But if you offer it in the physical examination sequences, like I want to complete my examination by doing bedside force vital capacity, then you can skip that part. But if you want, there is no harm in mentioning that.
Okay, thank you, sir.
Most welcome. Actually, this thing is something else. For every diet, I arrange a separate session covering the neurology short cases. And this is actually free for the registered candidate. Here, all the possible prompts coming in the PACES exam are discussed along with the physical examination sequences, also with the differential diagnosis flowchart and investigation and management. For diet 3, it is also going to be arranged later on. So let's come back to the mark sheet again. This is the mark sheet which the examiner is getting at his hand. So in the physical examination, we have already discussed how the marks are assessed. If you cannot confirm your diagnosis, if you rule out if you don't rule out the complication and miss important part of the physical examination, then mark will be cut. Like you maybe get some borderline. Let me give an example. For this myasthenia gravis patient who is having swallowing difficulty, if you start your examination by doing the general examination, like checking the anemia, then checking for jaundice, checking in the mouth, sometimes you may miss to auscultate the lungs, ruling out aspiration pneumonia. So that is going to affect your mark, truly speaking. So that's why, from my experience, if you can try to organize the physical examination in the form of triple CA, it is not necessary that all the time you will get all the components. But if you try to formulate the case in the form of triple CA, you will not miss any important part. And in this course, in these 250 cases, you will understand how to organize the triple CA. And that is your homework. I will give you guidance for that. Now come to the identifying physical signs skill. So regarding this skill, we have to know that in the PACES exam, two types of cases are given. One is dummy case. Another is real patient. For some center, it happens that both the cases can be dummy. Why it is important? You will understand who is dummy and who is real just by looking at the patient. But the thing we have to know that for dummy patient, you will not get any positive physical findings. And in the PACES exam, it is strictly inhibited to synthesize any finding. Because even if you synthesize one physical finding, all the marks will be unsatisfactory in this skill. Whatever positive findings, whatever wonderful positive findings you have got, doesn't matter. If you synthesize even one positive finding that is not there, it is automatically going to be unsatisfactory. That is 100% sure. And only for synthesizing finding, many candidates have lost the pass mark in the identifying physical signs because it is considered a great crime in the PACES exam. Let me give an example. There's a very much popular case in the PACES exam. The prompt is blood vomiting. And after entering the station, you'll see that a young boy is sitting in front of you. Most probably he is a medical student or a doctor working there. He's telling that from today morning, I'm having lots of blood vomiting, about 5 to 6 times. And the cause is peptic ulcer disease because he took painkiller due to some joint pain due to getting hurt while playing football, and he did not take the tummy protective medication. So this is very simple. I'm going to discuss detail in the GAT prompts how to approach for blood vomiting. But the important point is that from our clinical experience, we know that anyone having 5 to 6 times blood vomiting, this patient is surely going to have some conjunctival pallor. But whenever you are going to examine this patient, you will never ever get any conjunctival pallor. No positive findings of anemia will be there. But only to match your diagnosis, if you say that I have got anemia in the physical examination, you can be sure that you are going to get unsatisfactory only for synthesizing the finding. That's why be very careful. May I know, is this clear to all? How the identifying physical science is assessed? Don't go for
But doctor,
Yes,
can
doctor.
I ask question? Yeah, but if there is no anemia, how can I match this case as
Yes,
a as because this patient have vomiting 5 times, 6 times? If it is dummy
blood
case,
vomiting.
then
Yeah,
how do will I say at the end of this
from
examination
the history.
findings? That is,
Only
yeah.
from the history. That is the
Oh,
unfortunately that is the real pattern of PACES exam. Because in the PACES exam, they will give the patients who is stable. They will never ever give you any unstable patient. They will
right.
take they will take care take utmost care of the safety of the patient and also for you. That's why you will never ever get any real emergency case in the PACES exam. In the PACES exam, one station like you are going to face the long clinical consultation at station 2 and station 5. At one station, you will get a stable case for which admission is not needed. And then that case will be emergency for which admission has to be done. So what do you think? Emergency patient will be stable? I got my case in Pondicherry. It was a case of meningitis. But the patient was not having any high temperature. Whenever I was feeling his skin, he was not having any neck jamming, that is uh, neck stiffness. And I passed,
Then your
yeah,
finding was normal, but you diagnosed as a case from the history,
yes,
huh?
yes, doctor.
Understand.
Unfortunately, that is the pattern of PACES exam. And for matching my diagnosis, if I synthesized my finding that I have got the neck jamming, then surely my mark would be lost in the identifying physical science. Unfortunately, this is the pattern of PACES exam because they will not keep real emergency patient in the PACES exam. In this, I passed my PACES exam in the second attempt. My first attempt was at Bangalore. I'm going to discuss the story behind that. So at that stage, at Bangalore, I got a case of pulmonary embolism who was complaining of her chest pain just by laughing at me. She was laughing and telling me I'm having chest pain. I was admitted into the hospital for last 3 days and I was not getting any findings there. Because she was a healthy lady, 35-year-olds, some good healthy lady, no leg swelling, nothing was there. But I have to mention pulmonary embolism for that case. That's why we have to know what kind of cases comes in the PACES exam. In this course, once you complete the course, once you know what prompts comes in the PACES exam and what are the possible cases, like these 250 cases, you will automatically understand which case is for PACES and which case is not for PACES. Like in MRCP part 1 and part 2, we have solved a lot of cases of pyoderma gangrenosum.
Yeah.
But I can make you guarantee, in the PACES exam, you will never ever get it. Because this is an unstable patient and this will pose an issue of safety both to the patient and both to the examiner and also the candidate. That's why bullous pemphigoid or pemphigus vulgaris, these are actually not PACES exam. I have not seen personally in last 4 years any type of bullous lesion coming in the PACES exam because this bullous lesion can rupture anytime, which can create some complication. This can create some like a situation which is not comfortable for at all. That's why you don't have to practice the cases for bullous skin lesion. In this course, I try my level best to give you an idea what type of case you have to practice for long clinical consultation at the PACES exam. Sounds clear, doctor? Is it clear to all?
Okay, thank you.
Okay. So this is the identifying physical science. And again, be careful about telling any positive physical findings unless you are uh, confirmed about any positive physical findings. Don't mention anything about that, and be careful about dummy case. In the PACES exam, half of the time the case will be dummy, and for some centers, both the cases can be dummy, both for both long clinical consultation. This has happened for multiple times. Now come to the clinical communication skill. And this is the skill where the candidates face the most difficulty. And in this whole course, we will discuss mainly on this. This skill actually depends on how you are going to take history from the patient, how you are ruling out the important differential diagnosis, whether you are touching every important component of history, and how you are talking to the patient, whether you are professional or whether you are not professional. So this comprises the clinical communication skill. Now I'm going to start discussion about this in details. So after entering the station, we have to do some introduction. And be careful, doctor. In the PACES exam, actually, if you can create a good impression that you are a smart doctor, you are a confident doctor, and your communication skill is actually good, then you will surely get some benefit. It happens. Even you may not be so much clinically efficient, but you are smart and you are confident. You have to show your confidence in front of the examiner, and you have to practice for that. So how to introduce yourself after entering the station? You can use this flowchart. You don't have to take notes. This PDF sheet for the introduction will be provided to every registered candidate separately. So for this, you don't have to make notes. You can just listen to my voice, how you can do the introduction. You just have to memorize the things and practice with each other until the next practice session, where you will be assessed individually. So what is how to do the introduction? In the introduction, you have to first say, suppose, let me take a doctor, suppose Dr. Probir Sarkar. So in the PACES exam, you have to use the surname, not the first name. So I am using as Dr. Probir Sarkar as the candidate. So we have to mention that, hello, sir, I'm Dr. Sarkar, one of the doctors working here today. And always keep a smiley face. This will look professional. I have personally got benefits for keeping this kind of approach. It was written in my feedback. So, hello, sir. I'm Dr. Sarkar, one of the doctors working here today. May I confirm your name and age, please? I am here to talk to you about your problem and examine you. Is that okay? We have to take permission. We have to confirm the identity. Every point of this flowchart has importance, and it will count your mark in the skill of clinical communication skills. Actually, for the clinical communication skills, we have to do a lot of work. Then you have to tell your agenda that I am here to talk to you about your problem and examine you. Is that okay? So you are taking permission to talk to the patient, and you are taking permission to examine him. Then to show your professionalism, you have to tell, if at any point you have a question, please feel free to interrupt me anytime. From the outside, you will carry a paper with you where you can keep some note. So as you are carrying the notes, the patient might think that that doctor is taking some of a personal note. So you have to ensure that confidentiality, which is very much important in the PACES exam. Whatever words you are uttering, all are heard by the two examiners. So to ensure the confidentiality, you have to say, I may take a few notes during our conversation, but rest assured, everything remains confidential. Then ask the problem in open question. How to ask in open question? So in your own words, could you please tell me what brings you here today? Sometimes some candidate prefer to ask close question, like the prompt is swallowing difficulty, and the candidate is going to ask that, from your GP note, I have come to know that you are having swallowing difficulty. Can you please tell me more about that? This is a wrong approach. Why? Because in the PACES exam, 70% of the time, the surrogates are helpful. If you ask him one question, he will give you a lot of information to get your diagnosis. So in order to give him the chance, ask the question openly. What brings you here today? If you ask the close question that tell me only about your swallowing difficulty, then he is surely not going to give you anything else information else other than swallowing difficulty. So to give him a chance, please ask the open question that what brings you here today? Then the patient will describe his or her symptoms. Right after hearing the symptoms, before starting for history taking, we have to show the empathy. How to show the empathy? I am really sorry for your sufferings. Let us see how can we help you in this regard. So this comprises the introduction part. And from my side, I will suggest just to memorize the flowchart and practice it with your partner. In the PACES exam, you will not get enough time to think and reproduce. You have to prepare beforehand what to do, what to say, how to perform. And in the exam, only your reflex will work. That is muscle reflex. So may I know if there is any question regarding the introduction part, how to say the introduction? If it is clear, please give me a thumbs up reaction so that I can proceed forward with the next part. Okay, it's clear. Now we have to do the symptom analysis. For most of the symptoms, we can do the symptom analysis using this mnemonic, that is ODPARA. What goes for ODPARA? O goes for onset. Onset means sudden onset or gradual onset. How did it start? Suddenly or gradually. D means duration. For how long you are having this symptom? I means initial episode. We have to ask, is it the first time or have you had this type of symptoms before? All of them have importance. Let me give an example. One of the case came at Kochi Center or Chennai Center. It was in the last diet. The patient was having headache. It was a young patient who is having headache for a long period of time. So he was complaining that, okay, let me tell it later on. Let me discuss it later on. I means initial episode. So is it the first time or have you had this type of symptoms before? Then P goes for progression. Progression means is it gradually increasing day by day? A means aggravating factor, that anything increase your symptoms. R means relieving factors, anything improve your symptoms. And A means associated features. For most of the cases, you will not get any positive findings in the associated features unless you ask them specifically. Now, let me tell you regarding the long-term symptoms, like why duration is important. Let me give an example. That case I was discussing. A case came at Chennai. It was 35-year-old male. He was complaining of headache. So he was telling that I'm having headache for last 15 years. So what do you think? Any patient is having headache for last 15 years. Why he has come now instead of coming 14 years back or 15 years back? What is the reason for that? Can anyone guess? Any volunteer doctor? Yes. Any doctor? Can you guess why the doctor has come 15 years after this headache?
Change in severity.
Yes, doctor. That's why we have to ask this question. If the symptom is long term, we have to ask, is there any recent pattern of changes in the symptom? After asking this question, the patient replied, recently, initially the headache was on one side, it was some type of throbbing headache, but right now I'm having diffuse headache. And the headache is increased by coughing, sneezing, and bending forward. So what do you think? What is the diagnosis right now? Earlier it was migraine. Any volunteer? Yeah, raised ICV. It can be a brain tumor. So for any long-term symptom, if we don't ask that any recent change in the pattern, he is not going to give you the right information. This happens for every time. The surrogate is instructed in such a way that unless you ask the question, he will not give you the answer. So for some candidate who doesn't know this trick, he will get the diagnosis of migraine for this 15 years long period. So it is actually not professional that any patient having migraine headache coming after this 15-year period. So that's why this is very much important. We have to ask for how long you are having this symptom. And if you find the symptom is long term, you have to ask any recent change in the pattern of symptom. It is also true for any long-term symptoms like cough, like the COPD patients having long-term cough. But if there is any recent change in the pattern of cough, like bloody cough, what do you think? What can be the diagnosis? Any volunteer doctor? Any COPD patient with bronchitis who is having long-term cough, if he comes to you with the complaint of cough, and whenever you are asking, is there any recent change in pattern, he is going to give you the answer, yes, and recently I am having bloody cough. Yes, Dr. Rijwana is right. It is carcinoma of the lung. And unless you ask recent change in pattern for any long-term symptom, most of the time, the surrogate is instructed in a way not to give you the answer. So please keep this thing in the mind. So this is for Odipara. Then for any type of pain, we can use the mnemonic liquor. It is my personal mnemonic. You can use your own one like the Socrates, or that's also wonderful. But I personally use this liquor. Liquor means, L means location. Any type of pain, show me the site of the pain. It is the first question. Let me tell you an example why it is most important, why it is important. Like at one time at Pondicherry, 2 years back, a case came. The prompt was low back pain. So from the prompt, low back pain, we can guess that it is a case of musculoskeletal. But whenever the candidate asks, can you show me the sign? Then the patient showed him the renal angle, back at the back side. That is also back pain. But whenever anyone is showing you the renal angle from the back, what do you think? What is the cause of back pain? Any doctor, any volunteer?
Renal stone,
Pyelonephritis.
Pyelonephritis. Yeah,
pyelonephritis. Okay.
the patient was taking SGLT2 inhibitor. That's why for any type of pain, location is the first. And for any type of pain, apart from location, we can ask about history of trauma. First, ask any history of injury, then go for liquor. Then I for intensity. Intensity means how severe the pain is from 1 to 10. 1 being the lowest and 10 being the highest. And this is important because if the patient is in severe pain, you have to offer painkiller for that to show your professionalism. Whenever anyone is complaining of pain, like low back pain, I'm having severe pain, and the pain is 6 out of 10, you have to ask, do you need any painkiller or do you need any medication for pain? Whenever you are going to ask, tell this question to the patient, it will give an information to the examiner that this candidate is patient friendly. He knows how to perform safely with the patient. Is it okay, doctor? Clear to all? That's why intensity is a must to ask. And whenever anyone is in pain, please ask whether he needs any pain medication or not. Then Q goes for quality. We have to understand what is the nature of the pain and tell the patient to describe it. Give some example, like is it dull pain? Is it throbbing pain? Is it crampy pain? Give some example and tell him to describe the pain. The patient is surely going to give you some description. Then R goes for radiation. Radiation means after starting from pain, does it goes anywhere else? And this goes for liquor. So with this Odipara and liquor, you will be able to analyze 60% of the PACES prompts. For the rest of the 40%, you will not be able. But for that cases, whenever I'm going to discuss the prompts, I will give you the exact sequences of questions that you have to know. Like in the neurology, is the neurology prompt we are going to have later on. What questions you have to ask for each of the given prompt. You will get a written detailed screening question for that. So you don't have to worry for anything else. You just have to make the notes from the prompts. Then you have to start performing with your examiner. Like if the prompt is fever, you have to ask these sets of questions. For every type of prompt, what initial questions you will have to ask, you will get it in the prompt session. So don't worry. This Odipara and liquor is for 60% of the prompts, not for all. The rest of the 40%, I will tell you in written, I will give you the written sets of questions. What questions you can ask for symptom analysis. So that's all for symptom analysis. May I know if there is any question from this part before proceeding on to the next part? If there is any question or confusion, please Please feel free to ask me or give a thumbs up reaction so that I can understand you have understood. 2 doctors have understood. Yeah. Let me see. Dr. Probir, any question from your side? Okay. I think it's clear. I will request the doctors that please don't hesitate to ask me any question, because it is also, I don't know all the answers. I also learn from all of you. And I was on your side just a few days before. If you have any confusion, that is actually my failure. So please don't hesitate. Even if you have any confusion, even after completion of this prompt, feel free to ask me anytime at my WhatsApp for the registered candidate. I will try to make your confusion clear at any way possible. But you have to give your full efforts to me. Then we have to do the systemic review. So let me go to the flowchart again. If we follow the flowchart, after introduction and symptom analysis, we can go for systemic review. Then we can go for PDF Sajit. PDF Sajit means past medical history, drug history, family history. Sajit means smoking, alcohol, job, impaction on daily life, and driving. So this is the usual sequence: that symptom analysis, then systemic review, then PDF Sajit. What goes for PET and 5P, I'm going to discuss later on. So this is the usual sequence. But I'm going to tell you something secret. The secret is that right after symptom analysis, if you go to this PDF portion, that is past medical history, drug history, and family history, in more than 80% of cases, sometimes in 100%, you will get your diagnosis. Even before going for other and analyzing of the symptoms or anything else. This is 100% guarantee. Let me give you some example. These are real PACES cases example. And right now it is again going to be interactive. I would like to hear from the candidates to see who can give the answer. I'm going to discuss some real PACES cases. So at one time a case came. This case is actually a little bit older case. This appeared 3.5 years back at Bangalore. The prompt, it was a 45-year-old male with fever. So the fever was for 20 days. And the candidate to whom I talked, he was telling me that he was not getting any clue what was the cause of fever. Then even he started to ask the past medical history, drug history, and family history, like in the given sequence. He was going to ask. In this PDF sheet, you will get in written sequences what questions have to ask in the past medical history, drug history, and family history. The surrogate or the patient was not responding to any one of the questions asked in this sheet. Only one. Right after end of, like, whenever the session is going to be ended, just 2 minutes before, the candidate asked for any recent procedure. Then the patient replied that 1.5 months back, I had a dental procedure. No other clue. There was no stigma of anything else. He was a complete normal patient. That is a pure dummy. So anyone having dental procedure 1.5 months back and he's having fever for 20 to 25 days, what do you think? What is the diagnosis?
Infective endocarditis.
Yes, doctor, infective endocarditis. And truly speaking, it is not truly speaking, you will never ever get any real infective endocarditis patient in the PACES exam. It was a purely dummy case. Even he was not having any congenital heart disease or any valve replacement. Even after that, this is the only clue. And if you don't ask for any recent procedure, he's not going to give you the answer. That's why in this PDF sheet, I have given all the necessary things that you have to ask for the past medical history, for the drug history, and also for the family history. In the past medical history, you have to ask, do you have any past medical condition I should be aware of? Any surgery before? If you don't ask for any surgery before, he is not going to give you the surgical history. Let me give you an example. This is my example. Whenever I appeared at Pondicherry, I got a case. It was 35 years old, male with headache. The prompt was headache. From that outside, the blood pressure was given 130 by 90. Pulse was something like 94. And the temperature was given 38 degrees Celsius. My task was talk to him, examine him, and meet his concern. After entering into the station, I just saw that he was a stable patient. He was wearing a gown, a 35-year-old male with black complexion and lean and thin person. Whenever I just analyze the symptom, headache with odipara and all the things that I have to know for symptom analysis of headache. Then I asked any past medical history I should be aware of. He denied. I don't know. Right after then I asked any surgery before. Then he replied, 5 years back, I had a road traffic accident, and then I had a surgery at my tummy. Then I again asked, can you please remember what was the name of the surgery? He replied, I don't know. So what I did, I just removed the gown from his tummy and looked at his tummy. What I saw, there was a splenectomy scar. So from the doctor volunteers, can you now guess your diagnosis? Any patient having headache with fever, with splenectomy scar, what is the diagnosis for this headache?
Meningitis.
Yes. Meningitis. What kind of meningitis?
Meningococcal.
No. And not necessarily meningococcal, it can be pneumococcal also. So why
Encapsulated.
encapsulated? Yes, encapsulated meningitis. And if you don't ask for surgery, any surgery before, the surrogate is not going to give you the information of surgery. That happened to my side. I asked for any surgery before. He replied, then I had a road traffic accident 5 years back. So what do you think, doctor? This patient is having encapsulated meningitis. What important next question we should ask? Can anyone guess?
Any rash anywhere in the body?
Okay, this is a good question, but what important question in the history we have to ask? Why this patient is having? Yes, Dr. Priya has given the right answer. Please, doctor, unmute your mic and share your views in voice. That will be helpful for other doctors also. Dr. Loshita is also giving the right answer. Yes, doctor. Dr. Priya, please proceed on.
Like, do you take your recommended vaccinations?
Yes. How can you use the term vaccination without using jargon for PACES exam? Dr. Priya?
No, I'm not sure.
Shots. Shots.
Sure.
I asked this question, that did you take your recommended shots? He replied, no. Then I asked why. He replied, I work as a truck driver. I live in a slum. I cannot afford. So as a safe doctor, I have to arrange for financial support for this patient. So I referred him to a social worker for this financial support. And all these things were counted for my clinical communication skill. Is it clear, doctor? So apart from vaccination, what another question we should ask? Any doctor?
Medications, antibiotics.
Yes, doctor, antibiotic. Same. I asked him, did you took your recommended antibiotic? Again, the answer was no. The reason was he is a slum dweller. He cannot afford the antibiotic. So I referred him to the social worker. So do you think I should go for anything else? Even within 2 minutes, it did not take for 2 minutes. Within 1.5 minutes, I got my diagnosis. This is a case of encapsulated meningitis. The patient was not having any neck jamming. Nothing was there. He was only having splenectomy scar. That's why past medical history, drug history, I'm going to give you some example for drug history and family history. And family history, they are actually blessings for the long clinical consultation of PACES exam. right after symptom analysis, if you go for them, in more than 80% of the time, you will get your diagnosis and also the differential diagnosis. But you have to know what questions you have to ask for past medical history, what questions you have to ask for drug history, and what questions you have to ask for family history. Right? In the drug history, if you ask for, do you have any medication list? May I have a look? Then you have to ask, are you compliant? That if you don't ask any recent introduction or withdrawal of any medication, the surrogate is not going to give you the answer. Let me give you another real example. This happened to one of the doctors of this course. She passed from, again, Pondicherry. So she got a case of, her case was 50 years old, male with parectal bleeding. So in my course, I again repeatedly give emphasis on asking the past medical history, drug history, and family history as soon as possible. So she proceeded the same way. Whenever she asked for past medical history, she got history of mitral valve replacement. It was mentioned as a surgical history. Then in the drug history, he mentioned, I am taking warfarin. Then she asked this line, any recent introduction or withdrawal of any medication? Right after that, the patient replied, recently, for a sore throat, I took clarithromycin. So what do you think? What is the cause of parectal bleeding right now?
Clarithromycin.
Yeah, clarithromycin induced. What is the term? Full term? Any doctor?
Hepatic enzyme inhibition by clarithromycin.
It is over warfarinization due to clarithromycin.
Overdose. Yeah.
Yeah, it is not overdose. It is overcoagulation. The dose was actually right, but there was some drug interaction with clarithromycin.
Yeah, inhibitors. Yeah.
Yeah. So if you don't ask for any recent introduction or withdrawal of any medication, he is not going to give you the answer. That's why you have to know for this line. And you have to memorize this line after you getting the PDF sheet. Then one important thing in the drug history is medication allergy. This is easily overlooked by most of the candidate. But from my experience, for every diet, at least 2 or 3 centers will give positive allergy history to the medication, which has nothing to do with the real diagnosis. But if you are not able to identify the allergy to the medication, it will surely affect your mark in the clinical communication skill. Let me give you again real example. One of the doctors who passed from this course, actually this course started from September 2025, and he was one of the first candidate of this course. His name is Dr. Partho. So he passed from Delhi. He got a case of loose motion. It was bloody loose motion for 3 days. The cause was infection, and there was a positive family history of malignancy. So we have to rule out the malignancy again. The thing is not that. The thing is that in the medication history, he asked any history of medication allergy. The patient replied, 5 years back, I had a bug infection of my chest. Then I was given penicillin. And right after that, I developed some severe allergy. So the doctor told me that I'm having penicillin allergy. This penicillin allergy has nothing to do with the real diagnosis of bloody loose motion. But at his carousel, he was the only candidate who could identify this penicillin allergy. And from my experience in the last 1 year, I have seen that whenever the allergy is given, all the time, the penicillin is the culprit drug. I don't know why. It has happened for every diet. Not all that carousel. It has happened for every diet. At least 2 or 3 centers will give positive penicillin allergy. And the British are very much obsessed with this penicillin or this allergy to medication. That's why you have to ask for any allergy to any medication for all the patient. Now let me give you another example. How PDF is going to help you. This is a very much popular case. This case has come so many times that I myself has become bored of it. This case has recently been repeated in Hyderabad Center again. The case is breathlessness with cough. It was a 60 years old female. The prompt was cough with breathlessness. The past medical history, she is having rheumatoid arthritis, and the drug history, she is taking methotrexate. So what do you think? What is the differential diagnosis? Please reply, doctors.
Pulmonary fibrosis.
Arthritis and methotrexate-induced lung disease.
Yes, the diagnosis is ILD. The culprit is either rheumatoid arthritis or methotrexate. This thing is that much simple. That's why I repeatedly mentioned this. They mentioned it that long clinical consultation is actually very much easy. Once you understand the pattern and practice it for a repeated period of time, it will become very easy. And from this course, from my experience, I have been able to successfully provide arrange for full mark in the LCC up to now for most of the candidates. I cannot make guarantee of other stations, but most of the candidates are able to get full marks because LCC is actually very much easy. We just make some panic just for no reason. Yes, luck matters for some time, but this is less than 3% of the time. Sorry. But once you understand the pattern and know how to gain your diagnosis, how to perform professionally, it is very much easy. One another reason is that this PACES exam is actually not a specialist level exam. This is something important we have to know. Right after passing the MRCP PACES exam, you are going to enter there at ST3 level. You are going to perform there as a registrar, not as a consultant. Almost every time, whenever you are going to enter the exam station, one British doctor will come and say you that this exam is a very well-to-do exam, and we are keeping the cases that you face in your everyday life. And we are not judging you as a consultant. We are judging you like a safe doctor. So they want from your side whether you are safe or not. You don't have to know a lot of knowledge. Because British doctors don't want knowledgeable doctors. They just want safe doctors. They just want to know whenever you need help, are you able to escalate? Do you know whom to ask and whom not to ask? In this whole course, I will give you a detailed training how to escalate whenever you will feel helpless. Like for rheumatoid arthritis, sometimes you may face difficulty that for ILD, what treatment will you provide? No need of knowing the treatment. You just can mention, I will refer him to the rheumatologist. Let me give you my example. I got the case of meningitis headache due to meningitis. There was a British lady, she asked me that what antibiotic you would like to start. I was just blank. I couldn't remember the name of the antibiotic. I just mentioned I would like to take help from the infectious disease doctor. And she was satisfied. She gave me full mark. But I said one important thing. I admitted the patient and mentioned maintenance of airway breathing circulation. So she was worried about that part, whether I'm able to stabilize the patient. As a register there, we have to ensure that part only. We don't have to know a lot of knowledge for passing the MRCP PACES exam, because after entering the ST3 level, you will be given training as ST4, 5, 6, 7, and even sometimes ST8. Then you will be declared as a consultant. And the PACES exam is actually not a specialist exam. It is actually a diploma exam assessing you to enter into the ST3 level functioning as a registrar who works there safely and able to correlate every department. So there's a lots of talking. Let me give you another example how PDF can help you. Let me give you a real example. Like within few days, a case came just few days before in Hyderabad. The prompt was again parectal bleeding. So in the past medical history, again, there was mitral valve replacement. In the drug history, he was taking warfarin. Whenever she asked any recent intake or withdrawal of any medication, he replied, Recently, I have taken a painkiller due to some joint pain. I actually got hurt myself. That's why I took naproxen. And in the family history, there was a positive family history of bowel cancer. So what do you think? What should be the differential diagnosis for this parectal bleeding? I'd like to hear from the doctors. Any volunteer? Hello, doctors. Is anybody able to give the answer? Dr. Faria, can you hear me?
Yes.
Can you give the answer?
I do some differentials. It can
Yeah.
be warfarin toxicity.
Why? Why warfarin toxicity?
Though no drug interaction.
What is this?
NSAID-induced peptic ulcer disease.
Yeah, but NSAID can also cause warfarin toxicity.
Okay. Can it reduce hepatic metabolic?
Something like that.
Okay.
NSAID increases the effect of warfarin. That's why the patient was having bleeding from upper GIT.
Okay. Okay, Bhaiya.
So what do you think? NSAID is causing peptic ulcer disease as your secondary. What important question you have to ask to the patient?
What is the color of the
No. I'm saying patient is telling you that I have recently taken a painkiller.
Okay.
So for any type of painkiller, what next question should you ask?
Are you taking tummy protective medicine?
Exactly, doctor. And the patient replied, no. Indicating it was a
Then
peptic
it
ulcer
can
disease.
be a differential, like peptic ulcer disease.
Yes, peptic ulcer disease. Second thing is over anticoagulation. Anything else?
What is the age of the patient then?
He was 45 years.
Can it be can we suspect cancer also?
Yes, doctor. That's why family history of bowel cancer was there. And there was history of weight loss also. That's why I'm mentioning past medical history, drug history, family history is very much important. And for every GIT prompts, you have to ask about family history of bowel cancer. This is a must. Whenever I'm going to discuss the GIT prompts, you will see there. Family history of bowel cancer is a must to ask question for every GIT prompts. The last DT will be bowel cancer, which has to be ruled out because he has family history of bowel cancer, which was early onset bowel cancer. And to rule out the bowel cancer, we have to arrange colonoscopy because we are safe doctor and we have to arrange for that. Is it clear now to every doctors? Any question or confusion? Let me give you another example. The prompt was, it was 60 years old. All these cases you will get in the PDF case notes. These are real PACES cases. I'm not synthesizing any single case. All the cases I'm discussing right now, and all the cases you will find in this PDF case notes, these are real PACES cases. I have collected them personally over the last 4 years. So let me see who can give the answer. This 60 years old male has come with back pain. This is real PACES case. In the past medical history, he was diagnosed with prostate cancer 2 years back. In the drug history, he's taking flutamide. Flutamide is a form of anti-androgen. So right after getting this information, what differential diagnosis can you give? Any guess?
Prostate cancer with bone metastasis.
Yes.
Yes. Another
One
is
is
androgen deficiency.
So why androgen deficiency is possible?
Osteoporosis or
Flutamide.
osteoporotic
Yes.
fracture.
Osteoporotic fracture. Osteoporosis does not cause back pain, but osteoporotic fracture causes. Good job, doctor. Osteoporotic fracture. This case can be given like a 55-year-old female has come with back pain, past medical history of breast cancer. This case has again come. That's why past medical history, drug history, and family history is actually a blessing of PACES exam. Let me give you another example. There are lots and lots of examples. I'm just emphasizing on this part because I find it very much interesting. And just by this mentioning this thing, I have seen a lot of candidates passing the PACES exam, at least the long clinical consultation. Also, it helped me personally. Let me see who can give the answer. It is a real PACES case. It was a 35-year-old male has come with headache. So it is certain severe headache. In the past medical history, he has hypertension for 10 years. In the family history, there's family history of kidney disease. And the medication history, so drug history, he's taking medication for hypertension. So just by looking at this report thing, what do you think? What is it? Yes, Dr. Rizwan has given the right answer, but what is the cause of subarachnoid hemorrhage?
ADPKD.
Yes,
Belly
Dr.
aneurysm ruptures, belly
Yeah,
aneurysm.
associated with ADPKD. Subarachnoid hemorrhage with ADPKD. So this is a hidden clue. If you go for past medical history, drug history, and family history as soon as possible, you will get your diagnosis for more than 80% of the time. My suggestion is right after systemic symptom analysis, go for the PDF. Complete the rest of the history taking in the form of Sajid. So what is Sajid? Let me tell you now. Sajid means, S means smoking. We have to ask, do you smoke? Then how many sticks for how long? If the patient tells you that, yes, I smoke for 20 sticks for 30 years, then you have to offer professional help to help him stopping the smoking. Then you have to ask for alcohol. Regarding alcohol, the safety limit for both male and female is 15 unit. So you have to ask, do you drink? If the patient replies yes, then how much unit in a week? Is it within social limit? If the patient mentions that, yes, I drink within social limit or I drink socially, next you have to ask, any binge drinking? Because binge drinking can cause problems sometimes. But if the patient complains that he drinks almost every day and it is beyond social limit, then you have to go for Cage questionnaire. So what is Cage questionnaire? It is C for, have you ever felt you should cut down your drinking? A for annoyed, have people annoyed you by criticizing your drinking? G for guilt, have you ever felt guilty about your drinking? E for eye opener. Have you ever had a drink first thing in the morning to steady your nerve or get rid of hangover? This Cage questionnaire has to be asked whenever the patient drinks beyond the social limit. Then we have to ask about the job. That, may I know what do you do for living? Then we have to ask how the question of impaction, how this symptom is affecting your job and daily life. If the patient complains that this symptom is affecting my job and daily life severely, then you have to offer professional help for that. This help can be offered from the patient's professional with occupational health worker or in the form of financial help. That's why we have to refer the patient to social worker. And if you don't ask any impaction on job or daily life, it will surely affect your mark in clinical communication skill. All the PDF subject has to be covered. Then D for driving. We have to ask, do you drive? Regarding this thing, again, I want to tell you something important. The thing is that we don't have to memorize all the DVLA rules for passing the PACES exam. Because in the UK, whenever you are having any confusion, you can take help from the respective department, just with a phone call, or you can arrange a referral of the patient to that department. So for some prompts, you have to tell the patient to stop the timing. You can understand just by looking at the prompt, and understand you can, and just by making your differential diagnosis. But sometimes, if you feel confusion whether you have to stop the timing or not, you can save your bag by mentioning one line. The line is, stop driving till further assessment. So you are not allowing the patient to drive and also not to drive. You are just stopping the driving till further assessment, till the condition is sorted out, till we find out what is happening with you, and you will get full mark. This is my guarantee. You don't have to know for how long the patient has to stop the driving for the stroke, for hypoglycemia, for acute coronary syndrome, all that stuff. It is not needed to do the memorize. And actually, and also I mentioned the British doctors don't want a lot of information. They don't want a knowledgeable doctor. They want a safe doctor. Whenever you are having any confusion regarding any guideline, you can take help from them, from the respective professionals. So that's why if you have confusion regarding whether you have to stop the driving or not, just mention stop driving till further assessment. And that completes the PDF SAGIT. My suggestion is after symptom analysis, complete the PDF SAGIT first. Then go for systemic review or the screening question of differential diagnosis that I'm going to discuss in the musculoskeletal prom session. But may I know, up to now, this PDF SAGIT, do any doctor have any kind of question or confusion? If there is confusion, please unmute your mic and feel free to ask me. And if there is not, please give me a thumbs up reaction. Dr. Omi, Dr. Faria, Dr. Akanksha, Dr. Nukia. Dr. Anika, do you have any confusion, doctor?
No.
Okay. So this comprises the PDF SAGIT. Then, for only 4 prompts that are cough, diarrhea, fever, and joint pain, we have to take the history of PET, exposure, and travel history. The mnemonic is PET. Let me give an example. At one time, a case came, it was a cough. He was also having breathlessness, and he gave history of pigeon raising. So what do you think? What is the diagnosis for this breathlessness or cough?
Oxygen low, vanity.
Sorry? What is the diagnosis? Yeah, hypersensitivity pneumonitis. Yes, doctor. You're right. A case came with a complaint of low back pain. And in the travel history, this case came at Pune. The prompt was low back pain with a 25-year-old male. And in the travel history, he gave history of recent travel to his father's cattle farm. So what do you think? Yes, Dr. Akanka is right. Brucellosis. And he was actually a dummy patient. There was no positive findings of brucellosis. For any type of diarrhea, traveling is a must. Just few days before at Bangalore, a case came with fever. And it was a 7-day fever. And he had recently traveled to Thailand with positive exposure history. So travel history positive, casual sexual contact is positive, having 7-day fever coming from Thailand. What do you think? What should be the differential diagnosis?
Seroconversion for HIV.
Yes, first we have to rule out HIV. Anything else? Let me give you another clue. He was also complaining of a rash at upper part of the chest, which is not there. It was a red rash. It was there for 3 days. And today is the 7th day of his fever. The fever intensity is reduced right now. What can you guess that? Another DD? No, not gonococcal, doctor.
Glandular fever.
No, doctor, it is dengue. Yes, Dr. Devashi, it is dengue. The rash she was mentioning, it was actually rash of Pichichi. It was Pichichi rash. That was again a dummy case with positive traveling history to Thailand and casual contact history while traveling to Thailand. That's why only for cough, diarrhea, fever, and joint pain, you have to take history of PET. Then for all female of reproductive age, you have to take the history of 5P. They are pill, period, pregnancy, abortion. I said abortion to make it remember. And last P is for partner. We have to use the term pill is birth controlling pill. Don't mention OCP. OCP is a jargon. You have to mention birth controlling pill. Then we have to ask about the question of period. Before asking for that, we have to say sorry to the patient that I'm sorry to ask you some personal question. What about your period? Then any history of pregnancy. So to ask again, any history of child loss for abortion. Then, do you have any partner? Ask about the question of partner at the beginning. Don't go for ask for pill question before asking for partner question. First, ask for partner. Do you have a partner? Any casual partner. Then go for pill, period, pregnancy, abortion, partner. I rearrange the sequence. I will put the partner at the beginning in this PDF sheet. So this question has to ask for every reproductive age female. If in the history taking, if you fail to symptom analyze, if you fail to ask the past medical history, dark history, family history, any component of the subject, specifically the impaction on job and daily life, because you are going to prove you as a safe doctor there. Then any component of 5P for reproductive age female, then surely your mark is going to be cut in the clinical communication skill. You can ask the systemic questions later on if you think you have time and it will help you. But you can directly go to the screening question of differential diagnosis, which I'm going to discuss later on for the musculoskeletal prompts. And what will be the screening question? You will get it in details. So these are the systemic review. You can go for it or you can not go for it. It is your choice. But at least do the general review and fever-related questions for all of the prompts. Then based on the given prompts, like if you are given musculoskeletal prompts, at least touch the musculoskeletal systemic question. If you are given a GIT prompts, at least touch the GIT systemic questions. If you are given a neurological prompt, at least touch the CNS systemic questions. And that's all for the clinical communication skill. So that's actually a lot of things, and you have to practice a lot, and also you have to learn a lot. So let me ask from the doctors, if anyone having any kind of confusion regarding how the clinical communication skills is judged. Any question, doctor, please feel free to ask me. Dr. Habiba, do you have any confusion?
No.
Okay. Dr. Nusrat, any confusion from your side?
No.
Okay. So if it is clear, now let's proceed to the fourth skill. The fourth skill is differential diagnosis. So in this course, for every given prompt, what differential diagnosis you have to consider, you will get it. So for this, you don't have to think that much level, because in this whole course is designed in such a way, for every given prompt, you will have a set of differential diagnosis fitted in your mind. So don't worry much, you will get it. But one thing I will mention you, that is from my personal experience. The thing is for only one prompt. Let me tell you what is that. That mighty prompt is chest pain. In the PACES exam, for more than 90% of the cases, the chest pain will be due to pulmonary embolism. You can match my word. The thing is that if in the differential diagnosis, there are any suspicion of pulmonary embolism, you have to mention it as the first DD, not even the second or third DD. If you mention it in the second and third DD, then surely you will lose your mark. That has happened to myself during my first attempt at Bangalore. I got a case of chest pain. The prompt was 35-year-old lady has come with chest pain. After entering, I was seeing that a beautiful lady, she was laughing and complaining of chest pain. She was telling me that I was admitted into the hospital due to some breathing issue for last 4 days. And right before getting discharged, I'm having sudden chest pain. So I mentioned, like, she was previously diagnosed a case of COPD because she was a long-term smoker. So from my personal experience, what I practice, what I see in my native country, any COPD patient having sudden chest pain, we rule out pneumothorax first. Then we rule out acute coronary syndrome. We consider pulmonary embolism at the last. So I can mention this accordingly. I mentioned pneumothorax, acute coronary syndrome, and last pulmonary embolism. So what I got in the feedback, one of the doctors gave me borderline in differential diagnosis. Another doctor gave me unsatisfactory. And I failed my pass mark in the differential diagnosis only for one. So that's why I request every doctors not to make the same mistake. If there is chest pain, look for any components of pulmonary embolism. How to identify whether it is pulmonary embolism? I will give you a 9 clotting questions, a set of 9 clotting questions. Just by asking these questions, you can have a guess, you can rule out the pulmonary embolism. And in the PACES exam, almost all of the time, chest pain is due to pulmonary embolism. And if it is pulmonary embolism, you have to mention it as the first, not even in the second or third. Otherwise, you will face the same consequences as mine. And the funny thing was that the examiner who gave me unsatisfactory, during my departure of the station, he was giving me thumbs up reaction. He was showing the reaction that I have made something good. And he was laughing, having some like chill-minded examiner. So that happens in the PACES exam. So again, chest pain, actually for any type of chest pain, pulmonary embolism is the first degree. Even if you get any other chest pain, like any Marfan syndrome patient having sudden chest pain, this is surely due to aortic dissection. But again, rule out pulmonary embolism by asking 9 clotting questions. I'm going to give you the sets of 9 clotting questions during our cardiovascular system prompt. So that's all for differential diagnosis. Any question from any of the doctors? I'm having no questions, doctor. I think for World Cup today, there are less attendance today. And less communication is happening today. Doctor, do you have any question? Any question from any of the doctors? Dr. Kashif, do you have any question, doctor? Dr. Losita, Dr. Amit, any question, any confusion?
No, doctor.
Okay.
I have a question, doctor.
Sure. Please proceed on.
Sorry to tell you that I have exam on November, 3rd week
Okay.
November. So can I finish within this time?
Yes, it is fairly doable. I'm not saying it just to reconcile you because I have seen it personally. This course is actually 2 months period course. And this course actually covers from the basic to the advanced. Whatever things you need to know before going to the bedside. And once you know what to look for, then it will be easier for you to perform at the bedside. Unless by just going to the bedside, you will become puzzled. What to know, what to look. And you will become frustrated that I have suffered a lot. I have suffered 3.5 years long for this long clinical consultation. And that's why I have built this course. So any other questions from any doctors regarding?
Thank you, doctor.
Most welcome.
Hello.
Yes, doctor, please.
Actually, I am the PACES examiner of third diet. My center
Okay.
is Delhi.
Okay, doctor.
I'm like a beginner actually. I have just started related PACES coaching 2 months ago and very much weak at LCC. My communication and short case is progressing, but to me they are not satisfactory till now.
Okay.
I'm asking about the LCC. Is it possible to cope up in these 4 months for me?
Okay, let me give you the real story of 3 doctors. They were the very first candidate of this course. I'm not revealing their name. Do you know about the center Kochi?
Yeah.
And this is one of the difficult centers because I have heard something about the Kochi feedback. I'm not sure about that, just heard from the feedback. So they were having no ideas about the long clinical consultation. They could not complete the course even. They had to attend the exam 1.5 months after attending, just within 1.5 months of starting the course.
Okay.
And 3 of the doctors, they are lady doctors. 2 of the doctors passed from Thiru, and 1 of the doctors passed from Kochi with 162 out of 168.
Wow, that's great. I only need to pass.
Everybody needs to pass. You only need the pass mark. But I'm saying it from my experience that if you get all the things in organized form and if you do your full effort, it is not like that you attend a session and then goes on. You have to practice mutually. In this course, I encourage everyone to do the practice. This mark sheet I will provide every one of you. And every day, like the active candidates, I will have one-to-one communication with each and one active candidates every single day regarding any type of confusion they face, and they have to practice mutually every day and have to report me. Otherwise, I will not leave them. And the next practice session, I will practice any of the cases given from the homework. You will get a separate access to the physical examination, investigation, and management videos. All of the doctors will get the access there. And there, all the physical examination sequences, investigations, and managements are discussed in detail to pass the PACES exam. By going to the recording, you have to make your own notes in this PDF case sheet. These will remain with you up to you pass the exam. And truly speaking, this is something not to share. These are not my synthesized cases. This is actually okay. Don't tell it. It is because it cannot be shared on public platforms. So once you make preparation for this case and start practicing mutually before the next practice session, then you will see that right after 7 to 8 sessions, you'll understand your difference. You can talk to any previous candidates who have already attended this course. Tell them what about their experience before starting the course and after completing the course. You will get your answer.
Okay, so you're telling that I have hope in these 4 months.
That depends on you. I will give my level best. If you practice mutually and give me the feedback, then I can guarantee you.
I will try my level best from my side too.
Yeah, actually, even I have seen that many candidates was not that much attentive. Even they have passed the long clinical consultation with good mark. But the candidate who was super serious, all of them have got 28 out of 28. Just yesterday, the day before yesterday, one of the doctors from UK, her name is Dr. Kansu Topar. She has passed from UK, getting full mark at both the long clinical consultation. And she did not practice even for a single session with me. So,
Another question from me.
yes, doctor.
Thank you for inspiring us. The thing
I'm
is,
not
after
inspiring.
registration,
Just
no, just
let me
your
tell you that.
experience. Your experience is inspires us. That's
Sorry, doctor.
your experience
Which one?
inspires us. That
My experience.
some candidates even just attend to 1.5 months they passed like this.
I have seen doctor, especially I have seen
Yes,
this thing
yes,
happening with Indian doctors because
yes, yes.
I have seen that within 2 and 3 months. For myself, it took 4 years to crack all the things. Truly speaking, whenever I was taking preparation, there was no things organized, and only for this long clinical consultation, I attended 18 online course and all the offline courses possible in Bangladesh and in India. Right after that, I have organized these things. I have identified what are the possible problems comes in the PACES exam, what are the cases that comes in the PACES exam. I have gone through a lot of tool. But whenever I started mentoring, I have seen that whenever candidates get all the things in organized form, it becomes very much easy to pass for them.
Yes, yes, doctor.
Like
So my
I'm,
question is, after this registration, you gave me this PDF, this notes.
I give this PDF of introduction. For the prom session, you have to take the notes. And you have to make, after getting this PDF case sheet, it has to be make notes with your own hand. You have to make the notes on the hard copy of this patient case. Like for every given case, if the same case comes to you in the PACES exam, what physical examination you have to do, what investigation you have to do, and what management you have to do, you will get these things in the recording access in this thing. Sorry. These are explained in details in this separate recording. This case is 40. Like for 250 cases, you have to make notes of the physical examination, investigation, and management only, nothing else.
So after getting registration, you will provide this. I'm just asking this.
Yeah, this is for registered candidate. Okay.
Okay, thank you.
Okay. So I'm just expecting some question regarding the mark sheet, because in this course I try my level best to make everyone as a mentor. I don't want anyone to come back again to me, because this course is actually a one-time course. I rarely allow anyone to repeat this course anytime, because I will not be able to provide you anything new for this course. So that's why what all the things you have to be prepared on one time. No come back again. I will not give you the allow for coming back again. Then,
Another question, doctor. Sorry,
doctor.
this review. So this note is available for type A and type B candidates.
Yes, type A and type B.
Yes.
Hopefully,
B.
type A seat slots will be booked within a few hour. All the slots will be completed. Only type 2 and type 3 will be opened. So, any question from the mark sheet? Because you have to practice mutually based on this mark sheet. So this thing has to be cleared.
I have one question.
Dr. Faria?
Hello.
Yes, doctor.
Hello.
Yes, I'm hearing, doctor. Please proceed.
I want to join as an active candidate. What should I do now?
Active. Okay, there is slots available at Monday. Okay, make me a knock after this session, because I will
Okay,
not be
okay.
able to communicate until the session.
Okay, okay. Thank you.
Okay. So I have
one question, please.
sure, doctor.
May I ask?
Sure,
Okay.
doctor.
What is the difference between type A and B? Sorry, I could not get it.
Okay, in the type A, actually there is accessible to the practice session. Right after doing the homework and practicing mutually, in the practice session, I will assess individuals one by one, how they have practiced in this 1 week. This is something like homework assessment. And I have seen that whenever anyone has some intention that I will be assessed in the next week, then actually this works a lot better, a lot. But for this active session, I cannot make allotment more than 10 persons, because each candidate needs 30 minutes to provide the feedback in details. So type A will get this practice session from me, and also any type of problem facing during doing the communication homeworks, any type of confusion. And every single day they have to report me regarding their practice, whether they have practice or not. I will make them just like this. I will disturb them whenever I'm free. I will disturb them. Have you practiced or not? If you don't practice, I will not allow you to leave. And in this course, you have to practice mutually. Yes, doctor. And type B is
type B?
in the type B, you will get the prompt session and all the homework materials, and all the things will be provided from a website as a dashboard. The website is actually on the way to be built. It will need 2 weeks more. Up to then, you will get all the access with the Drive link. But I will not be able to communicate with you one-to-one, because from the 3 batches with the 30 active candidates, I have to do a lot of work every day regarding their confusions, communications, all the things. So I will not be able to provide the same support to type B. This is the difference.
I got it. But how to get registered?
You have to knock me at WhatsApp. I'll tell you the details.
Okay. Thank
And
you.
again, you will be attached to a separate group of secret fighters. The candidates who have already completed the course at least for once, they are attached there. And after completing this course, even I actually don't just leave anyone. You have to continue doing the practice mutually. For that reason, I attach everyone at the Secret Fighters course. Already there are 150 persons there who have already completed the course. If you need any partner to practice, you can just give a post there that I want to practice from this system, if anyone is available there. And if anytime you have any kind of problem in getting the partner, please notify me. I will try my level best, because every time I get requests that I need partner, I need partner. So if anyone is having partner deficiency, please let me know. I will try to provide my help. But partnership is a must. You don't have to depend on myself only. You can only practice one case with me in practice session. But if you know how to practice, how to give the judgment, then every one of you will become the mentor. You will not have to depend on anyone else. It seems difficult during the initiation, but right after completing 6 to 7 sessions, you'll understand your difference.
I got it. Thank
Okay.
you so much.
Thank you, doctor. Any question regarding the mark sheet, regarding the differential diagnosis? Right after that, we have to know for clinical judgment. In the clinical judgment, what things are assessed? 3 things are assessed. One is safety netting. Sorry, 4 things are assessed. One is safety netting, whether you are providing enough safety netting to the patient if needed. Second thing is admission, whether the patient needs admission or not. You have to provide this information to the patient. This safety netting and information has to be provided to the patient. The next 2 things are investigation and management. You have to give the answer to the examiner. And all the things regarding investigation and management, you will get it in details in the separate recording. That's why I'm telling you that you have to make your notes from the recording for each given case. What physical examinations you have to do if any of the case comes in the PACES exam. You have to try to formulate the triple CI formula. You will get the details help in the recording. Then you have to make the recording of the investigation and management for each specific case. Because in the exam, regarding the investigation and management and safety netting and admission, your judgment will happen. And there are certain way how to guide your examiner. I will tell you in details. Regarding during the practice session, you will get it. Regarding admission, right before starting the examination, offer to check the vitals in the form of pulse, temperature, respiratory rate, oxygen saturation, sitting and standing blood pressure. And if anyone is having any abnormal vitals, then you have to admit the patient. Otherwise, it is not needed to admit the patient. Even after that, there is a way to save your bag. The way is, suppose you are having confusion that whether you have to admit the patient or you can discharge the patient. You can save your bag because the British doctors want safe doctors. They don't want like you will know all the things. Whenever you will need any type of help, you will get them. So you can say like this, the patient can ask you, do I need admission? You can say like this that I'm going to keep you at the observation room. In the meantime, I will talk to my consultant, we'll run some tests, and my consultant will come and see you, and I will be in a better position. We will be in a better position to give the answer. You will get full mark. Whenever you are having any lack of information, don't take risk. Even any type of decision, don't take risk. Take help from the senior. Let me give you my example. It happened with my communication station. I got a case of insulin overdose, and it was a medical error. And the patient was complaining that whenever I was taking the insulin in my home, I was not having this hypoglycemia or low sugar. So this is something error from your side, and allow me to take insulin at your hospital. I don't rely on the nurse. So actually, I'm not working at UK. I don't know the rules and regulations there, whether patients are allowed to take their insulin on. So what I told regarding this thing, I was honest. I just replied, regarding this thing, I don't know the right answer right now, and right answer at present. But I will talk to my senior and I will come back to you as soon as possible after this meeting ends, before you leave the room. I got full mark. So this is the reason I mentioned in the PACES exam, they don't want that you will know all the things. You will get help whenever needed. But certain few things you have to know, like whenever you have to admit the patient and like after admission, how to stabilize the patient. In the PACES exam, 2 types of scenarios are given at both the stations. One is stable case, another is emergency case. So during mentioning the management for all types of stable case, you have to mention education and counseling forming a multidisciplinary team. And for emergency case, for all types of management, you have to mention admission, management of airway, breathing, circulation, then education and counseling forming a multidisciplinary team. This thing has to be mentioned must. If For any emergency patient, you did not mention the admission and management of airway breathing circulation, surely your mark will be cut in the clinical judgment. Please keep this thing in the mind. And in this recording, I have discussed in detail for which case you have to say how to give the answer of management. So that's why I could give you the written notes, but I want everyone to write you with your own hands so that you know you will memorize it whenever you write these things. So that is why investigation and management you have to know. And regarding investigation, always start with apart from basic investigation. Then to confirm the diagnosis, what investigation you have to do to find out the cause, to find out the complication, and at last association. So how to even say the investigations, this thing you will get in detailed recording for the registered doctors for each and specific case in this PDF case notes. For 250 cases, you will get this in the recording. You just have to listen to them and make your own notes here. And all the things that if the same case comes to the PACES exam, what physical examinations you have to do, it is given in clearly in details in the recording. You just have to make your notes by listening to the cases. So may I know, is it clear how the clinical judgment is assessed in the PACES exam? Any question? If there is no question, please give me a thumbs up reaction. Dr. Faria is clear. Dr. Anika is clear. Dr. Saida is clear. Dr. Maya is clear. Dr. Faria, any question from your side?
Bhaiya, I am going to collect the notes, the hard copy. Then I have to make notes on my own. Like
Yes, doctor. Exactly from the given information in the recording. You don't have to think enough, but you have to make the notes so that you can memorize once by writing.
Then the access, when will you allow the access? Like you have
Right
2
after
weeks
today's night.
after 2 days.
Yeah, I will give you the access as draft link for right now. And from the dashboard, it will take 2 weeks. You will receive a login credential and you will get the access for 1 year long.
Okay, thank you, Bhaiya.
Okay, but I want you to know, are you clear how the clinical judgment are assessed? Is it clear to yourself? Because you have to provide the judgment to one of your partner from this course. You have to practice this. Dr. Faria?
Yes, as you said, we have to judge like who is stable and who is unstable. If the patient condition is unstable, then admit the patient, then airway breathing circulation like this.
Yes. So how the exam candidate is replying the investigation and management is assessed in the clinical judgment. It is the core thing. That's why in the recording, I have covered them. Apart from them, for some patient, you will need safety netting. Like any patient with Raynaud's phenomenon, you have to do the safety netting that avoid cold exposure, avoid path contouring pill, avoid beta blocker. That will also be considered in clinical judgment. And also, the patient, whenever the patient will tell you, do I need admission, whether you are admitting him or releasing him, that is also be counted in clinical judgment. Have you got it, doctor?
Yes, Bhaiya. Yes.
So you have to give the feedback to one of the registered candidate. And you have to practice that until the next practice session, whenever you will be assessed from my side. Then managing patient concern. In the PACES exam, you will get 15 minutes to do the interaction with the patient. And my suggestion is, okay, right after 13 minutes, whenever 2 minutes are left, you will get a signal from the examiner that 2 minutes are left. Complete all of your things regarding history taking and physical examination within this 13 minutes. And keep this 2 minutes solely for meeting concern. Because sometimes there are multiple concerns, like even 5 to 6. The patient will carry a paper with it on his hand, and he's going to ask one by one questions at along. And this is very much easy how to meet the concern. These are such simple mnemonic. But remember, don't use jargon. And don't go for explaining all the pathophysiology to the patients. It is not needed. Just use some simple things. You'll understand it once you start practicing mutually. It is very much simple, but you have to keep 2 minutes at hand. Like whenever the examiner is going to tell you 2 minutes left, stop all of your work and meet the concern. Then the last thing is patient welfare. Almost all of the doctors get full mark here. This is total 32 marks, and the pass mark is actually 28. And unfortunately, if anyone gets less than 28, he will not only fail, the RCP will not give him mark for the next diet also. It happens. Like if anyone has failed by getting 27 in welfare, the RCP is not going to give them a seat for the next diet. Their judgment is that I'm giving you time to be more professional. And whenever you are doing any examination to the patient, always take permission from him that I'm going to touch your ear. Whenever you are checking the anemia, I'm going to touch your ear. Whenever you're checking the trachea, I'm going to touch your windpipe. Is that okay with you? Whenever you are going to do the palpation of abdomen, ask him, do you have any pain? And whenever you are done with your physical examination, say him thank you at least 3 times. That thank you very much, sir. You have done a wonderful job for me. And help him to wear the gown. At the same time, the surrogate will come and take the job from you. But by doing this thing, you are giving a signal to the examiner that you are professional, and you will gain full mark in the welfare. It is actually the most easiest part. That is maintaining patient welfare. If you don't create any pain to the patient, you can easily get full mark in this welfare. And that's how the 7 skills are judged in the PACES exam. At best, each examiner can give you 2 marks for satisfactory. So actually, with each of the examiner, they have actually 14 marks in total. The mark will be summation. There will be a summation of marks from both the examiner. So it is 14 plus 14 is equal to 28. And all of you will hopefully get 28 out of 28. So that's all for the mark sheet. May I know if there is any confusion regarding the mark sheet? Please feel free to ask me any question, because you will get at least only for 2 to 3 days to take prepared. After that, you will have to practice. And all the candidates who have got the hard copy, hopefully you have got a PACES mark sheet with all of you. And you have to start practicing mutually. Any question from any of the doctors regarding the PACES mark sheet?
Doctor, I have a question that if I
Sure.
finish talking before this time, then what happens?
Sorry? I'm
You
not
said
getting.
just you will talk with 30 minutes, then 2 minutes for concern. So if I finish before 30 minutes, then what will
Yeah.
happen?
You can proceed on, but actually the thing is arranged in such a way that you will need 30 minutes for almost all of the cases. But if you become pro, then you can complete it before 13 minutes. And if you complete it beforehand, the examiner is not going to start unless 15 minutes is completed. So it happens that the examiner will keep staring at you, and you will keep staring at the examiner. Some of the candidates of this course, they have become so pro that they can complete the scenario within 10 minutes. So actually, there is no harm in that, but you have to try to touch all the possible things, and you will get an understand whether you have missed anything or not once you have completed this course and do the practice every single day. Any other question regarding the mark sheet?
Hello.
Yes, doctor.
I have a question. Sorry that I have missed some information.
Okay.
I want to know about what have to say in case of a stable patient and an emergency patient.
Okay.
Please tell me.
Yeah. In the PACES exam, station 2 and station 5, both of them are long clinical consultation. So surely you will get one stable case and one emergency case. Both of the cases will never be stable. or both of the cases will never be emergency. For every stable patient, you have to mention education and counseling, then forming a multidisciplinary team. And thanks for asking this question, because in the multidisciplinary team, one mistake we do frequently that I did myself in my first attempt. The thing is that we tend to utter the name of the members of the multidisciplinary team, like from the neurologist, psychologist, hematologist, then educational and professional worker, all the things we keep in them. Actually, in the PACES exam, the examiner are assessing us whether we are able to form this multidisciplinary team and whether we are mature enough to take the decision who has to be present in that multidisciplinary team. So it might happen that for some patient who does not need a hematologist, you are keeping hematologist there. That will surely affect your mark. That happened to my side. And this thing has happened not only for my side, it has happened to many candidates. Let me give you my example. I got a case at cardiac short case station. It was a case of mitral stenosis at Bangalore during my first attempt. So in the management, I started with education and counseling, forming a multidisciplinary team. And inside the multidisciplinary team, I started mentioning everything. Like I will keep a cardiologist, hematologist, then occupational worker. Right after mentioning the term hematologist, the examiner make me stop and ask me just by mocking that, so only for managing this mitral stenosis, you are going to arrange a referral to the hematologist? I again made an argument with him. I just mentioned that, yes, because before starting for anticoagulation for atrial fibrillation, I would like to take consultation from him. I would like to arrange a referral to him. Everything I just mentioned. And whenever the mark sheet came, I saw that I lost the mark in clinical judgment. I got 0 mark there. From that on, I never mentioned the name of the members of the multidisciplinary team. And I talked to many candidates who have faced the same consequences, because in the rush of the exam, sometimes you might utter the name of a person who should not be there. And the British doctor will consider that you are not mature enough. You don't know to whom you have to escalate. So that's why my suggestion is only mention multidisciplinary team. No need to mention the member of the team. So this is for a stable patient. For any emergency case like meningitis, like pulmonary embolism, if the vitals are abnormal, like subarachnoid hemorrhage, we have to admit the patient. And after admission, always there you have to manage airway, breathing, and circulation. Then education and counseling, forming a multidisciplinary. This should be the way. Then treatment of the underlying cause. Have you got it, Dr. Rita?
Yes, thank you. Thank you.
Okay. These things are explained for every cases in the recordings. You have to manage made the notes for yourself. And
I think this is not maybe in relation to this.
Sorry, doctor, your voice is not heard. Can you please make it loud?
Yeah, I have added question. Can you hear me?
No, doctor, your voice is again low.
So now is it clear?
It is again low, doctor.
I don't know why. So,
Okay, can you please proceed on?
My question is, please don't get it the way. If I get 0 in and 1 station in one skill, is it possible to cover it by other station?
Yes, it is fairly doable, because this exam is not assessed for individual station. It is assessed on individual skill, and all the possible 7 skills are assessed only in long clinical consultation. You have to pass with each skill individually. And thanks for asking this question again. Let me share you some wonderful experience for that. Like, this exam is actually skill-based exam. That's why what I have seen, if anyone is able to get full mark in long clinical consultation, both the long clinical consultation and both the communications, it is very much difficult for him or her to fail. Because by somehow, he gets pass in all the skills. And this exam is actually assessed based on the skills, not only on the stations. It happened that candidate has failed in 2 of the short cases, but he got full mark in LCC and communication and got moderate mark in other 2 short cases. He eventually passed the exam. This has happened for multiple times. And this long clinical consultation is the most important one, then communications. So that's why in this course, I request every candidate that try to ensure full mark in LCC and communication. You will come to the near of your pass.
Thank you
Most welcome, doctor.
for the information.
Okay, doctor.
Thank you.
So this is the mark sheet. Even after today's discussion, if any of the registered candidate has any confusion regarding how the mark sheets are assessed, please feel free to contact me. So just let me discuss the introductory session, something more else. Like in this PDF sheet, you will get the diabetes questionnaire. What questions for asking diabetes? Like in the diabetes, you have to ask some general question. Then you have to assess for compliance in the form of triple D. The drug, diet, and daily exercise. Then you have to assess for complications. There are two types of complications. One is short-term complication, another is long-term complications. There are two short-term complications. One is hypoglycemia, another is HHS or decay. So you have to ask this question that any episode of low blood sugar coma and any episode of high blood sugar coma. And long-term complications can be divided into three types. They are microvascular, macrovascular, and autonomic complications. Microvascular complications are diabetic peripheral neuropathy, diabetic retinopathy, diabetic nephropathy, and mesenteric ischemia. So all the questions are written here. You have to memorize this. Macrovascular complications are stroke or TIA, MI or angina, and peripheral vasculitis. And autonomic complications are postural hypotension, early satiety, then gustatory sweating, change in the bowel habit, and erectile dysfunction for male. So actually, whenever diabetes complication is given, this becomes very much difficult for candidate to perform. So unless you memorize it beforehand, it will become also difficult for you to perform well in the exam. In a separate access with a flowchart in the PDF sheet, you will get access what examination you have to do for any diabetes patient. And this diabetes complication, you have to look for whenever there is more than 5 years of diabetes for diabetes mellitus type 1, and whenever there is 10 years of diabetes for diabetes mellitus type 2. Otherwise, you don't have to assess and do the examination for complications. Like in the exam, you may get a case of 2 years of diabetes. For that patient, you don't have to go for these long lines. It is not needed at all. But if the candidate is having type 1 diabetes for more than 5 years and type 2 diabetes for more than 10 years, then you have to go for all the complications written in this PDF sheet. With another access, you will get a flowchart of examination sequences that you have to do for any diabetic patient. All of you will get this access with a drive link. You have to make notes for that. Even you can print out the diabetes examination flowchart and print, just make it attached in these notes. That is your choice. So may I know, is there any question or confusion from this diabetes scenario? Is a very much popular case for PACES exam. Any confusions? Okay. The last thing is connective tissue screening questions. You will get a flowchart of asking for any type of connective tissue covering the systemic sclerosis, SLE, dermatomyositis, polymyositis, and mixed connective tissue disease, also with rheumatoid arthritis. So there is a flowchart here that any change in color of your finger after exposure to the cold, that is Raynaud's phenomenon, any joint pain, stiffness, any skin thickening, any difficulty in raising the arm or getting up from the chair, any hair fall, then any grittiness of eyes and mouth, any eye redness, eye pain, any skin rash, any rash after going to the sun, any mouth sore, then any chest pain, any tummy pain, any change in the urine. These things are found in any type of connective tissue disease. Like Raynaud's phenomenon can be found in systemic sclerosis. Joint pain and stiffness can be found in rheumatoid arthritis, also in SLE. Skin thickening can be found in systemic sclerosis. Proximal weakness can be found in dermatomyositis and polymyositis. Hair fall in the form of discoid lupus erythematosus can be found in SLE. And this thing has happened whenever any will anyone will complain of hair fall, please remove the hairline of the scalp and look for any hidden rash of discoid lupus erythematosus. This thing has happened at Dhaka Center. The lady was having discoid DLE rash at the scalp, and unless you remove the hairline, you will not find this DLE rash at the scalp. So you have to know that for any connective tissue, you have to remove the scalp, remove the hair of the scalp and look for DLE rash, because eyes cannot see what mind does not know. Then grittiness of eyes and mouths are found in Sjogren's syndrome. Eye pain, eye redness can be found in uveitis, that can be found in rheumatoid arthritis. Then skin rash, facial rash, this is found in SLE. Mouth sore, that is hard palate sore, is found in SLE. Chest pain, tummy pain, this is symptoms of pleuritis and peritonitis. This can be found in SLE. And for any type of connective tissue disease, they can affect the kidney. So we have to ask the detailed kidney question. Any change in urine in the form of amount, color, frequency, and frothiness. So you can rule out any connective tissue disease by memorizing this flowchart. And that's all for this introductory session. We'll start our musculoskeletal prompt session. But before going for that, let me know if there is any question or confusion regarding how to take the history professionally. This is just an introduction. You have to practice it mutually. And don't worry, every registered candidate will get this PDF of introduction to the history taking. You have to memorize them. Any question from any of the doctors? If there's no question, please give me a thumbs up reaction so that I can proceed with our next part of our discussion today. Okay, 2 doctors are clear. Yeah, I think all are clear. Okay, so our next part is discussing the musculoskeletal prompt. Before starting for this session part, I would like to take 5 minutes break because I'm having some throat problem. I would like to take some 5 minutes, then we'll start discussing the musculoskeletal prompts. Till then, let's take a short break. Thank you, doctor. I'm coming just after 5 minutes later. So welcome back again, doctors. So our real prompt session starting. Pardon for actually the World Cup is going to start within 2.5 hours, the World Cup final. So I will try my level best to complete it beforehand. So these are the possible prompts that have come in last 4 years from this musculoskeletal system. These are hand pain, low back pain, knee pain, ankle pain, hip pain, shoulder pain, neck pain, diffuse body pain, or multiple joint pain. Among these prompts, there are frequent some prompts which are triple esters, like hand pain, low back pain, and knee pain. So what does it mean by triple ester? Triple ester means they are the most common comps coming in the PACES exam. This has been divided based on the importance. Then hip pain and shoulder pain, they are double ester prompt, and rest of them are the one ester. So let's start with hand pain first. So why I request everyone that not to repeat the course, because every time you will come to me, I will give you the same materials. I will try my level best to provide all the things from the basic to the advanced. So every time you will join my prompt session, you will find almost the same thing. Only few things will be changed based on the demand. So let's proceed with hand pain. In the hand pain, up to now in the PACES exam, 5 possible diagnoses has come. Apart from these 5 causes of hand pain, never ever any cases has come in the PACES exam. The causes are joint pain, Raynaud's phenomenon, carpal tunnel syndrome, Takasu arteritis, and arteriovenous fistula. So these are the possible 5 diagnoses for hand pain in the PACES exam. So suppose you have been given a case of a 30-year-old female has come with hand pain. Then how you should approach? Right after entering the station, at first you have to ask What do you mean by hand pain exactly? Is it joint pain? Or is it color change on exposure to the cold? That is Raynaud's phenomenon. Is it tingling and numbness relieved by shaking and cold water? That is carpal tunnel syndrome. Is it pain at hand while doing some activities? That is Takasu arthritis. This line has been repeated. Then can you show me the site of the pain? This is epifistula pain. This epifistula pain has come in the Delhi Center for 2 years at a long. But for the last 6 months, it is not being repeated. I don't know why. But this was actually a paid case for Delhi Center. That pain due to epifistula. So our job will be, if the prompt is hand pain, right after entering the station, we have to ask these five questions. Is it joint pain? Is it color change on exposure to the cold? Is it tingling and numbness relieved by shaking and cold water? Is it pain at hand while doing some activity? Or can you show me the site of the pain? If the patient shows you some AV fistula, this is fistula due to an AV fistula related cases. Then we have to ask Odipara and Liquor. For O, how did it started? D for did it start suddenly? Or O for how did it started? Suddenly or gradually? D for duration, for how long? I for initial episode, is it the first time? P for progression, is it gradually increasing day by day? A and R for aggravating factor and relieving factor. Anything increase or decrease your symptoms. Then we have to analyze the pain using the mnemonic Lee code. L for location. Where do you feel the pain exactly? It will be covered here already. I for intensity. What is the severity of the pain? 1 being the lowest and 10 being the highest. Q for quality. What is the quality of the pain? Is it dull? Is it sharp? Then R for radiation. Does the pain radiates anywhere? So this should be the common initial question for all type of hand pain. And right after getting the clue that if it is joint pain, if it is Raynaud's phenomenon, then we have to proceed accordingly. Suppose it is a case of joint pain. It has come multiple times, like in the Dhaka Center, it has come. The prompt was joint pain, the diagnosis was SLE. So how to approach for hand pain due to joint pain? First, we have to ask, is there any morning jamming, that is morning stiffness? If there is morning jamming present, we have to ask for how long. We have to see whether it is more than 30 minutes or less than 30 minutes. If it is more than 30 minutes, then for the PACES exam, there are only 3 differential diagnoses. They are rheumatoid arthritis, psoriatic arthritis, and SLE. If there is no morning stiffness present, then this is mechanical hand pain. For PACES exam, only 2 DD are there. They are gout and osteoarthritis. How to rule them out? What should be the screening question? In rheumatoid arthritis, patient will have symmetrical hand pain. So whenever the patient is mentioning that I am having pain at both of my hands symmetrically, you can keep rheumatoid arthritis as one of your differential diagnoses. To rule out the psoriatic arthritis, ask about any skin rash. To rule out the SLE, ask about any rash in the face, particularly after going to the sun. That is butterfly skin rash. And that is how you can rule out every differential diagnosis. Clear to all? Any question? Doctor, this session is going to be a little bit interactive. So if anytime you have any confusion, feel free to ask me. If you don't have any confusion, just give me a thumbs up reaction so that I can understand that every registered candidate is clear of their confusions. Then if there is no joint morning stiffness present, this is gout or osteoarthritis. What should be the screening question? For gout, you have to ask the question of podagra. What is podagra? Podagra is the grade 2 sometimes becomes swollen and painful. So just by pointing at the grade 2 of the patient, you have to ask any, let me write the line, any episode of pain and swelling at your grade 2. So any patient having gout, he will at least have one episode of podograph. So you have to ask this question that any episode of pain and swelling at your grade 2. If the patient complains of that, then you can keep gout as your differential diagnosis. In the later part, for the knee pain approach, I'm going to tell you how to find out the cause of gout with some wonderful mnemonic. Then if it is osteoarthritis, just by looking at the hand, you will be able to guess the diagnosis. Let me show you some real case. Like it has come in the PACES exam. This is from the PDF case notes. So this patient has come with hand pain. The hand pain was due to joint pain. The prompt was this. The hand pain was due to joint pain, and there was no morning stiffness present. There was no history of podograph, and you are looking these things. There are abundance nodes present. So just by looking at the hands of the patients and age of the patient, you can guess your diagnosis of osteoarthritis. This is real PACES case, and you will get it in the PDF case notes. So we have to rule out the osteoarthritis by looking at the patient's hand. You will get some abundance nodes or butcher's nodes in the patient's hand. So is it clear to all how to approach for hand pain due to joint pain? Are you confident now you can deal with any type of case? Any question? Is it clear or any confusion, doctors? Dr. Anika, any question from your side?
Clear.
Dr. Anika, do you have any question, doctor? Dr. Saida, any confusion?
No, doctor.
Okay. So in this way, hand pain is covered. And in the PACES exam, apart from this differential diagnosis, never ever up to now any case has come for hand pain due to joint pain. So you have to approach for any type of hand pain with this line. How to use the screening question, I hope you have got it. You have to make the notes from the recording and you have to start practicing for these cases. First, you have to make the note for physical examination, investigation, and management for each of the cases in this PDF case notes. Now, let's proceed to the next part. Suppose the patient is complaining of hand pain due to Raynaud's phenomenon. Whenever you are going to ask, what do you mean by hand pain exactly? She is telling, is it joint pain? No. Then whenever you're asking, is it color change on exposure to the cold? She's replying, yes. So you have got an idea that this is a case of Raynaud's phenomenon. Then you have to confirm the Raynaud phenomenon by identifying the 3 stages of color change. They are pale, blue, and red. You have to ask, have you noticed the color changes sequentially from pale to blue to red? Whenever you are going to ask this question to the patient, make your voice loud to make it audible to the examiner. The examiner will be impressed that this candidate is well prepared and he knows what are the stages of Raynaud's phenomenon. It happens like if the examiner does not hear you, he will not give you the mark. It has happened for multiple times that the candidate mentioned the thing, but the examiner did not hear it, probably due to age-related any issue of the examiner. So whatever things you will tell, please say it loud. So actually Raynaud's phenomenon, there are 2 types of Raynaud's. One is Raynaud's disease, another is Raynaud's phenomenon. In the PACES exam, we are given Raynaud's phenomenon. Raynaud's disease is whenever there is no underlying cause found, it is called Raynaud's phenomenon. It is found symmetrically. It occurs symmetrically at both the hands. And the age of patient is usually middle-aged female. But Raynaud's phenomenon is whenever the Raynaud's happen due to some secondary cause. Then it is called Raynaud's phenomenon, and this thing happens asymmetrically at both the hand. It is not symmetrical. So if anytime any Raynaud's phenomenon comes in the PACES exam, there are 2 differential diagnoses. One is either connective tissue disease, another is Buerger's disease. This Buerger's disease has been given at the Pondicherry Center in Diet 1. And connective tissue disease related Raynaud's phenomenon has come multiple times. So what should be the screening question for connective tissue disease? Just use the flowchart that I have discussed in the introduction. That any first identifying the Raynaud's phenomenon, ask for any joint pain, stiffness, any skin thickening, any difficulty in raising the arm, any hair fall, any grittiness of eye, any redness. In short, you can just ask any joint pain, stiffness, any rash, any skin thickening. In the PACES exam, mostly the systemic sclerosis patient is given with Raynaud's phenomenon. This is the most common case. Sometimes SLE or sometimes mixed connective tissue diseases are given. All the diseases of connective tissue disease can be covered by allowing these flowchart questions. Sounds clear to all? Can I expect thumbs up reaction? Dr. Akanka, any question from your side? Okay. Then suppose the case is Burgess disease. How can you identify? Just after entering the station, if you see any patient having amputation at both the upper limb and lower limb, and he is complaining of Raynaud's phenomenon, that is color change on exposure to the cold, be sure that this is a case of Burgess disease. You will get the same kind of case in the PDF case note. These cases come in the Pondicherry, the diet one. It was 40 years old lady. After entering the station, it was found that the lady was not having many fingers at the hand, and also some fingers were lost at the leg. So how would be the screening question? The other name of Burgess disease is thromboangiitis obliterans. It is typically an individual of less than 45 years old with evidence of tissue loss at hands and at feet that happened with Pondicherry case. You just have to ask, do you smoke? How many sticks for how long? Then there is a particular characteristics of Burgess disease, that is superficial thrombophlebitis. It is migratory superficial thrombophlebitis. This type of migratory superficial thrombophlebitis is also found in case of Behçet's disease, but it is also found in case of Burgess disease. So how can we ask this question without using jargon? We can ask, have you ever noticed a painful red tender line or lump under your skin, especially in your arms or legs? Does it appear at one place, settle down, and then come back in another place? This is the migratory nature, and this is the thrombophlebitis. So both together, you are asking for superficial thrombophlebitis question. And truly speaking, few candidates will come to know this question, that superficial thrombophlebitis can happen in Burgess disease, and this can be asked without using jargon in this way. So my suggestion is take your notes from the recording, and whenever you are getting any hand pain due to Raynaud's phenomenon, due to Burgess disease, use this question. And just after asking this question, your diagnosis of Burgess disease is completed. You don't have to go anything else. Just complete the PDF Sajid and 5P if needed. And for every type of Raynaud's phenomenon, you have to do the safety netting. That is, wear gloves, avoid beta blocker, bipitting tool, and avoid birth controlling pill. Never tell oral contraceptive pill. It is a jargon. You have to mention birth controlling pill for every type of Raynaud's phenomenon. And that's all for Raynaud's phenomenon. Let me know from the doctors if there is any confusion or questions from this Raynaud's phenomenon. If there is no question, please give me my gift. Is there any confusion present? Dr. Probir, are you having any confusion or question, doctor?
No confusion.
Are you clear about
Yes.
how to approach for Raynaud?
Yes.
Okay. Dr. Lasita, are you having any confusion regarding approach to Raynaud's phenomenon?
No, doctor, they're clear.
Okay. So in this way, we have completed the second part. So the patient, whenever you're asking what do you mean by hand pain, you are asking, is it joint pain? She says no. Whenever you ask, is it color change on exposure to the cold? Again, she is saying no. Then whenever you are asking, is it tingling and numbness relieved by shaking and cold water? She says yes. Then it is carpal tunnel syndrome. This is a very much popular prompt of PACES exam. Carpal tunnel syndrome comes in many ways in the PACES exam. And all the time, whenever carpal tunnel syndrome will be given in the PACES exam, it will be given on the background of weight gain that I have seen. Sometimes there may be many other causes, rheumatoid arthritis, trauma, tumor, trimming. But this type of case is not given in the PACES exam that I have seen in last 4 years. Like any rheumatoid arthritis patient, I have never seen given with the prompt of hand pain due to carpal tunnel syndrome. All the time, carpal tunnel syndrome is given with the background of weight gain. So if the patient complains of tingling and numbness at hands that is relieved by shaking and cold water, this is carpal tunnel syndrome. We have to ask about weight gain. In the endocrinology prompt, again we'll discuss how to approach for weight gain. So regarding weight gain, we have to ask, is it intentional or is it unintentional? How much weight has he got over how long? Then the differential diagnosis for any weight gain is two types, whether it is localized weight gain or whether it is generalized weight gain. For localized weight gain, it will be acromegaly and Cushing. For acromegaly, the screening question is for enlarging of hand. That have you noticed that your hands and feet are getting enlarged day by day? For Cushing syndrome, it will be center obesity. So the screening question will be, have you noticed you are gaining weight around your face, back of the neck, and around your tummy? So it is peripheral weight gain mostly, and it is central weight gain. And this is the screening question for acromegaly and Cushing. And if the patient complains that he has put on the weight all over the body, so we have to ask, where have you put on the weight? Is it on the hands and feet mostly, or is it on the face, back of the neck, and tummy mostly, or is it all over the body? If it is all over the body, this is generalized weight gain. For generalized weight gain, in the PACES exam, only 3 differential diagnoses are there. They are hypothyroidism, polycystic ovarian syndrome, and obesity due to overeating. How to rule out hypothyroidism? Just ask about weather preference. How to rule out polycystic ovarian syndrome? Just ask about any abnormal in periods. And always say sorry after asking about period, because you are asking personal questions. Then obesity due to overeating, ask about what about your diet. Take the dietary history, whether he eats a lot amount of food or not. Then, can anyone tell me what should be the most important differential diagnosis for bilateral carpal tunnel syndrome? Any volunteer doctors? This is very much important because it was considered in Dhaka Center. Only for not missing this, mark was cut. In the PACES exam, never ever you will get unilateral carpal tunnel syndrome. You will get bilateral carpal tunnel syndrome. So for bilateral tingling and numbness that is causing carpal tunnel syndrome, what should be the most common? What should be the differential diagnosis?
Hypothyroidism.
Sorry.
Hypothyroidism.
Hypothyroidism. No, the hypothyroidism is the cause of carpal tunnel syndrome. I'm saying the differential diagnosis of bilateral tingling numbness.
Differentials.
Hypocalcemia.
No, doctor. It is written in the screen. It is cervical myelopathy. It is also called cervical myeloradiculopathy. That's why you have to examine the jerks of upper limb only to rule out cervical myeloradiculopathy. It happened at Dhaka Center at Diet 3, 2025. The case was bilateral carpal tunnel syndrome, and only for not examining the jerks of upper limb, the candidate lost his mark in the physical examination skill. Because the most important differential diagnosis is cervical myeloradiculopathy for any type of bilateral carpal tunnel syndrome. That's why don't miss to check jars for both hands. or bilateral carpal tunnel syndrome. Then for any type of weight gain, whatever the causes, up to now, you will face a lot of case with weight gain. For any type of weight gain, rule out 3 complications from the history, from the physical examination, and also from the investigations. From the history, we have to rule out carpal tunnel syndrome for any type of weight gain, then obstructive sleep apnea, and osteoarthritis of the knee joint. How to rule it out? Like you may get a case with weight gain. For carpal tunnel syndrome, you just have to ask any tingling numbness and hands that is relieved by shaking and cold water. For obstructive sleep apnea, any nighttime snoring. For osteoarthritis, any knee pain. And that's all for carpal tunnel syndrome. But please, doctor, don't forget to rule out the 3 complications of any type of weight gain, because weight gain is a very much popular prompt. You can get this case with many other ways. And never forget to check jerks of upper limb in bilateral carpal tunnel syndrome, because the most important differential diagnosis is cervical myeloradiculopathy. So doctors, any confusion from any of the doctors? If there is no confusion, please give me a thumbs up reaction so that I can understand that everything is clear to all. This carpal tunnel syndrome is very much important for PACES exam. So please do a lot of focus on this. This can seem to be simple. Most of the cases are simple, but actually in the PACES exam, candidate miss the pass mark only for making simple mistakes. Sorry to say, it is the truth. In the PACES exam, you will never be very rarely be given a difficult scenario. Then come to the next type. Suppose the patient, you are asking that, what do you mean by hand pain exactly? Is it joint pain? Is it color change on exposure to the cold? Is it tingling numbness relieved by shaking and cold water? All the things, the patient has replied no. Then whenever you are asking, is it pain at hand while doing some activity? The patient is replying yes. Then this is tachycarditis. The case came at Kolkata Center. So this is tachycarditis. And the important thing of tachycarditis is that you have to check for all the pulses and the bruit. That is carotid bruit, subclavian bruit, and renal bruit. Don't forget to check for all the bruits of in case of tachycarditis. And you have to feel for radial pulses, radial delay, radiofemoral delay. But if you want, you can skip examine the lower limb pulse. Can you guess why? Any doctors? Why pulses of the lower limb can be omitted? Any volunteers? Can anyone tell me why pulses of lower limb can be omitted in case of tachycarditis?
Because it is peripheral region and upper limb from direct from the heart.
Actually,
Giant
doctor.
keratitis.
Okay, actually.
Aortic arch is involved.
Yes,
So
aortic arch is involved.
from there.
That's why. This question was asked by the British doctor to the Kolkata candidate. He did not examine the lower limb pulse. And the British doctor asked, why did not you examine the lower limb, the pulses of the lower limb? He replied this, that actually tachycarditis affects a branch of the arch of aorta. That's why I did not examine for the lower limb pulse. He got full mark. So that's why you have to know for this. And you have to know where you have to look for subclavian bruit. It is below and above the clavicle at each side of the chest. You have to listen to the carotid bruit and renal bruit also. So that's all for tachycarditis. Then come to the next part. If the patient denies all the 4 things, that there is no joint pain, no color change, no tingling and numbness, and no pain while doing activity, just mention, can you please show me the site of the pain? And in the past medical history, you will get some kidney issue and the patient is undergoing dialysis. Again, PDF is a severe. But whenever the patient will show you the site of the pain, you will be able to see the AV fistula. which was actually a very much common case in the Delhi center for 2 long years. But for some unknown reason, for the last 6 months, this case is not being given. So what are the possible causes of AV fistula pain? The possible causes are, oh, one thing was missed. The first cause will be infection. Okay, it was written here, sorry. So what are the possible causes of fistula at the AV fistula pain? It can be due to aneurysm of the AV fistula. It can be due to ischemic steel syndrome. It can be due to local infection. It is called infected AV fistula. Or even it can be due to thrombosis or stenosis of the AV fistula. Regarding ischemic steel syndrome, you will not be able to feel any peripheral pulse, that is radial pulse will be absent. So you have to feel for that. And these are the possible 4 causes of pain due to AV fistula. This question will be asked if the pain is hand pain is due to AV fistula pain. This was a hallmark case for Delhi, but this case has been removed. So hopefully it will not be repeated. But you have to know that. So that's all for the differential diagnosis of hand pain in the PACES exam. Up to now, and the last 4 years, no other hand pain case have come in the PACES exam apart from this case. But for every type of hand pain, as I have mentioned that during physical examination, we have to formulate the triple CA. So one of the C was complication. So from the physical examination, we have to check the complications of hand pain. So can any volunteer share? Do you have any idea how to check the complications of hand pain? What examination can we do? Any guess? Okay, let me tell you. We have to check the functional capacity. For any type of hand pain, never forget to check the functional capacities of hand. How to check the functional capacities? We have to tell the patient, make a fist and open it for me and try to button and unbutton your gown for me. This is very much simple. In the physical examination video, also you will get detailed manifestation by me, where I will show you how to check for functional capacities of hand. But any type of hand pain, never forget to check the functional capacity. Any type of leg pain, like ankle pain, knee pain, hip pain, low back pain, never forget to check the gait. For all the prompt, we have to rule out the complications from the examinations. Then these are the screening questions. These are the questions of obstructive sleep apnea. That do you feel fresh? Any headache? This morning headache. Do you feel dizzy the whole day? Any problem in intimate relationship? And nighttime snoring. We can use the question nighttime snoring as our screening question, and the rest of the 3 are our confirmatory question. Please remember these things also. So that's all for hand pain prompt, which was actually a large prompt. Let me know from the doctors if anyone having any kind of confusions up to now. Again, you will get some physical examination flowchart in the form like this, like acromegaly clinical features. What things you have to do, look for, like in the hands, in the face, in the neck. These things are actually built based on the requests of the participants. Up to now, in the last 1 year, candidates has requested me that we need this type of flowchart. Then I just prepared these things for them. And all the things that have prepared up to now, all of the registered candidates will get the access. So again, if you need any such type of help from my side, please feel free to tell me. I'll try to make the flowcharts for you. That what the things you have to look for in any acromegaly patient. I can make it for clinical features, also for physical examinations. Just you have to inform me. But let me know now first that if there is any confusion regarding the hand pain approach. Is there any confusion? Dr. Akanka is clear. If there is no confusion, please give me a thumbs up reaction so that I can proceed on the next low back pain. Okay, all up. The doctors are clear. So the next prompt is low back pain. Again, it is a triple star prompt. Triple star prompts mean these cases comes every now and then. So my request will be also that look at the cases that comes at different centers. You will get this case at Secret Fighters group that all of the registered candidates will be added separately. And you will identify once you, at the end of this course, you will identify that all the courses, all the cases actually have certain pattern. In the PACES exam, actually they follow certain pattern. What kind of case they provide. If you can identify the pattern, then it will become very much easy for you to get the full mark at LCC. So the leg pain, low back pain, again, we have to look at the site because this can be pyelonephritis, which was once a case of Pondicherry. The prompt was from outside low back pain. For any type of pain, always look at the site of the pain. Tell the patient, can you please show me the site of the pain? So the patient showed the renal angle from the back. And it was a case of pyelonephritis. But maximum case will be musculoskeletal pain. So suppose if the case is musculoskeletal pain, what should be the first question? First question is ask for morning jamming. If the patient complains of morning jamming, check whether it is more than 30 minutes or less than 30 minutes. If it is more than 30 minutes, then it is inflammatory back pain. For that, only there are 4 differential diagnoses. If there is less than 30 minutes, then there is mechanical back pain. For that, there are only 8 differential diagnoses. After asking for morning jamming, analyze the symptom using the mnemonic ODPARA. Onset, duration, initial episode, progression, aggravating factor, relieving factor, and associated features. And for all the types of low back pain, ask the red flag signs. Never forget to ask the red flag signs. Red flag signs are whenever there is any cord compression, or whenever there is any metastasis to the cord, or whenever there is any inflammatory back pain, they will show some red flag signs. The red flag signs are all the things are mentioned here. There are 5 red flag signs. Any weakness, any change in sensations around the private parts, that is saddle anesthesia. Any change in sensation in the lower part, this can be found in Cauda-Equina syndrome. Any loss of bowel and bladder work, this can also be found in case of flaccid bladder due to Cauda-Equina syndrome. Does the pain wake you up at the night? This is the most important red flag sign question. Because whenever any nighttime awakening happen due to low back pain, this will be either metastasis or inflammatory back pain due to ankylosing spondylitis. And this is the most important red flag sign question. Never forget to ask for red flag sign questions for any type of low back pain. Just follow the sequences shown in the slide. Then based on the presence and absence of low back pain, the differential diagnoses are 2. One is inflammatory. For that, in the world, there are 4 differential diagnoses. One is ankylosing spondylitis. Second is psoriatic arthritis. Third is reactive arthritis. Fourth is enteropathic arthritis. Now come to the screening question for each. For ankylosing spondylitis, there is no screening question because the low back pain is the only presenting symptoms for ankylosing spondylitis. For psoriatic arthritis, we can ask for any skin rash. And we have to know every possible areas where psoriatic rash can appear. In the physical examination video, I have demonstrated personally what are the possible areas where you have to look for psoriatic skin rash. And this is very much important because it happened at Delhi Center one time that the patient was having a rash at the knee joint. And the candidate did not elevate the gown and could not identify the rash at the knee joint. That's why mark was cut in the physical examination, also in the identifying physical sign. That's why we have to know every possible sites where psoriatic rash can appear. I have demonstrated it in the physical examination video, and you will get this as access. Then for reactive arthritis, we have to ask any discharge from your private part, that is urethritis. For enteropathic arthritis, it is associated with IBD. And there are two IBD. One is Crohn's disease, another one is ulcerative colitis. To rule out the Crohn's disease, ask any loose motion. To rule out the ulcerative colitis, ask about any blood in the motion. Like the normal candidates would ask any change in bowel habit. That is absolutely okay. But the advanced candidate from this course, I will suggest you to ask specifically any loose motion to rule out the Crohn's disease, any blood in the motion to rule out the ulcerative colitis that can be a causative factor of enteropathic arthritis. May I know, is it clear to all? Any question regarding the screening question of any inflammatory back pain? Is it clear to all the doctors? Dr. Amit, are you clear?
Yes, clear.
Dr. Anika, Dr. Parveen, is it clear to all of you?
Yes.
Okay. Now come to the mechanical back pain. Mechanical back pain can be due to trauma. Just ask any history of injury. Then it can be septic back pain. This is called discitis. This septic back pain can be due to tuberculosis, can be due to discitis, can be due to brucellosis that we have already discussed. The patient will have high temperature. Suppose this case you will get patient is having low back pain. In the past medical history, patient had recent episode of injury to the lower limb while gardening. So what do you think? What is the cause of back pain for this patient? Any volunteer? I'm again mentioning 60 years old male who is having diabetes for 2 years. He is having low back pain for last 2 days. And he has recent injury to the lower limb while gardening. So what is the cause of this back pain? This is real PACES case. You will get it in the case sheet. Any doctors possible?
The PLID.
Sorry?
PLID.
I'm again mentioning patient temperature is high.
Discitis.
Yes, discitis. This is discitis. This case you will get it whenever you will start doing your homework. This is real PACES case. All the cases are real PACES case. Yeah. This was, no, this is, this was the case. In this case note, you will get a detailed description of each of the case. How the case came, what is the past medical history, drug history, family history, smoking, alcohol, job, impact on daily life, all the things, information are given there. All differential diagnosis that you have to consider. Also, it is written in these case notes. In the PACES exam, you will be given only this picture. I have provided in this way so that you can practice mutually. Whenever you are practicing with your partner, just show him this page and tell him to prepare. Then you will act like a surrogate using this information. So this is a real PACES case. Whenever there is high temperature, low back pain, ask for recent procedure or recent any history of recent injury. Unless you ask this question, the examiner, the surrogate is not going to give you the answer. That's why in the past medical history, I have mentioned here any recent history injury. All the things I will suggest you to memorize and practice telling this with your partner from this course. Because the surrogate are instructed in such a way that if you don't ask for specific questions, they will not give you the right answer. And all the questions mentioned here have specific importance. You don't have to understand that for which scenario, which thing we have to mention. I will suggest memorize all. It will take at best 1 minute to complete all the questions of past medical history, drug history, and family history. Then it can be due to osteoporotic fracture, like one of the scenario we discussed earlier. Patient had past medical history of that is prostate cancer, and he is taking flutamide and suddenly having low back pain. So differential diagnosis, can anyone mention? Okay, let me ask this question. I think that usually my sessions becomes interactive, but
Osteoporotic fracture.
So osteoporotic fracture and metastasis due to
yes, osteoporotic fracture and metastasis. Actually, doctor, at every session, I try to give some real basis cases to the candidate and show how they can answer after I discuss each of the given differential diagnosis. But I think today, due to the World Cup final, everybody has some rush to complete it before end, including me. But you will get all the cases in the PDF case sheet. Then it can be due to osteoarthritis of the lower back. It can be the metastasis. It can be due to multiple myeloma. These cases come in the last 6 months multiple times. Even in the Dhaka Center recently, this case was given. Actually, the prompt was tummy pain from outside. Can anyone guess what is the cause of tummy pain for multiple myeloma?
Hypercalcemia.
Yes, doctor, hypercalcemia.
calcemia.
Yes. Actually, the surrogates are helpful at most of the time that the prompt was from outside tummy pain. Right after entering the station, the candidate, he was a candidate of this course, he asked, what brings you here today? The surrogate replied, I'm having tummy pain, I'm having low back pain. So you have got your diagnosis. The mnemonic is CRAB, hypercalcemia, renal abnormality, anemia, and bone pain. So he was having tummy pain, he was having low back pain. Also, he thinks he is getting paid day by day. That is anemia, giving the diagnosis of multiple myeloma. Do everyone know what does it mean by CRAB?
Yes.
Yeah. CRAB, C for hypercalcemia, R for renal abnormality. From the outside, okay, for that prompt, from the outside, renal function test report was given. And the prompt was tummy pain. After entering, it was shown that it was a 55-year-old male. And after asking for what brings you here today, the patient replied, I'm having tummy pain and low back pain. And it was actually a tummy case. In reality, he was not having any anemia. But from outside again, renal function test was given, which was abnormal, and hemoglobin was given, which was given as 7.1. So from outside, it was given as hemoglobin 7.1. But from inside, the patient was not having any conjunctival pallor. That happened at Dhaka Center this day. So that's why I'm saying you not be careful about saying any positive physical finding. And this is a recognized trap.
But I have a question
Sure.
regarding this. I mean, if examiner is asking me question, should I mention the anemia parts? Like
You have to
I'm
mention,
having
you
physical
have to be
sign,
you have
but
to be
I'm having
technical.
7.1, right?
You have
So what should I say?
you have to be technical. Like you have got evidence of anemia from the investigation given outside. You have to mention like this. Like whenever you are giving the diagnosis of multiple myeloma, the examiner can ask you, what are your judgment for multiple myeloma? You can say patient has features of hypercalcemia in the form of polyuria, polydipsia, low mood, tummy pain, this is peptic ulcer disease, tight motion. Patient is having abnormal renal function test from the reports given outside. Then he is having anemia, evidenced by the report given outside. Don't mention that he has anemia evidenced by physical examination.
Yes, yes. Okay. Thank you so much.
Okay. You have to be technical like this. In the PACES exam, there are many ways to be technical to save your back. I will teach you how to give technical answer during the practice session. And never go for all the answers in one go. Never do it. Because if you complete doing the answer, the examiner will jump in another portion. And there is certain way how can you guide the examiner. And most of the time, if you can reply the investigation and management in proper and organized way, they will give you full mark in clinical judgment. But they will not stop asking. You might think that your station has become not good because the examiner asked you a lot of questions and you are not able to give the answer. But whenever the mark sheet will come, you'll see that they have given you good mark. But due to the anxiety that I did something wrong at the station, your next station performance will be hampered. That's why to save the next station, there is certain way how to give answer in slow and easy way. I will tell you later on. Then for any sudden pain, PLID can be given, and psoas hematoma is a recognized cause of back pain. Okay, let me ask you. It was again a PACES case. You will get it in the case notes. The case is 45 years old male has come with low back pain. In the past medical history, he takes warfarin, and in the drug history, in the past medical history, he has mitral valve replacement. In the drug history, he takes warfarin, and recently he has taken an antibiotic, azithromycin. So, what is your diagnosis?
This may be a case of psoas hematoma.
Yes,
It's a hyperwarfarinization.
Yes, that's his PACES case. That's why I'm mentioning again past medical history, drug history, and family history. They are actually blessings for long clinical consultation of PACES exam. Apply this trick, you'll find your way. And for any type of low back pain, from the physical examination, always examine the gait to rule out the complication. And examine the lower limb neurologically. No need to examine all the parts of lower limb neurological exam. Only check the plantar. Truly speaking, in the PACES exam, you will never be given a case of cord compression. But whenever you are just checking the plantar, it will give a signal to the examiner that this candidate is professional, he is experienced, he knows how to rule out the cord compression. You don't have to check the tone, power, reflex, coordination, sensation. All the things are not needed. Just check the plantar to rule out the cord compression and examine the gait to rule out the complications of low back pain. And that's all for low back pain. By following this flowchart in the PACES exam, you will be able to crack any type of case, also in your real life day-to-day practice. So let me know from the doctors if there is any confusion from this low back pain approach. Please feel free to ask me, doctors. I want you not to go home after taking any confusion. If there is no confusion, again, give me a signal.
No confusion.
Okay. Yeah, so many. Dr. Amit, are you clear, doctor? Dr. Amit? Okay. So in this course, actually, I try to communicate with every doctor's register, especially the active one. And you have to report me about your confusion and about your practice.
Hello.
And yes, doctor?
Yes, I am clear. I was taking a glass of water.
Okay. No issue, doctor. So
Okay.
sometimes you might feel disturbed regarding every day. Sometimes I may poke you that do practice, have your practice. But whatever you do, I will not leave. This is the, and I will not disturb you anytime 2 months after. But you have to do the practice.
I want the disturbance to be perfect.
Yes. Okay. Let's see. How can you proceed on?
Okay.
The next prompt is knee pain. It is another triple star prompt. So how to approach for knee pain? Again, first we have to ask for morning jamming. If there is morning jamming present or absent. If the patient complains of morning jamming, ask for the duration, whether it is more than 30 minutes or less than 30 minutes. Then do the analysis with the mnemonic ODPARA. That is onset, duration, initial episode, progression, aggravating factor, relieving factor, and associated feature. Analyze the symptom using the mnemonic liquor and ask for any other joint pain. Then based on the presence of or absence of morning jamming, we have two types of differential diagnosis. One is inflammatory knee pain, another is mechanical knee pain, where the morning stiffness will be absent. Excuse me, let me drink a glass of water. So for inflammatory knee pain, the differential diagnoses are all the seronegative spondyloarthritis plus rheumatoid arthritis. The seronegative spondyloarthritis are ankylosing spondylitis, psoriatic arthritis, enteropathic arthritis, and reactive arthritis. What will be the screening question? Already we have discussed. For ankylosing spondylitis, no screening question is needed because, oh, okay, for ankylosing spondylitis, the screening question will be any low back pain. This is the presenting feature of ankylosing spondylitis. So we have to ask for any low back pain. For psoriatic arthritis, we have to ask about any skin rash. For enteropathic arthritis, again, can anyone tell me what should be the professional question? Let me see who can remember.
Loose motions.
Loose motion. Loose
Then,
motion.
Is a blood in loose motion. Blood in
yeah,
motion.
blood in motion. Good job, doctor. Any loose motion, any blood in motion. For reactive arthritis, we have to ask any discharge from the private part. And whenever we are asking any other joint pain, if the patient complains of other knee pain, then we can keep rheumatoid arthritis as one of our differential diagnoses. That like the patient is complaining of right knee pain. Whenever I'm asking any other joint pain, she's mentioning I am having the same kind of pain at my left knee joint. Then automatically for any type of symmetrical inflammatory joint pain, we can keep rheumatoid arthritis as our differential diagnosis. I hope this is clear to all. Now, if there is no morning jabbing present, then it is mechanical knee pain. The mnemonic is very easy, ghost. G goes for gout and pseudogout, H goes for hemarthrosis, O goes for osteoarthritis, S goes for septic arthritis, and T goes for trauma. Now come to the screening question. For gout, what can the screening question? Can anyone remember? I have discussed. Any volunteer doctor?
Photograph.
Swelling.
Oh, swelling.
Any painful swelling at the great toe. Any episode of painful swelling at the great toe. So this will be the screening question of gout. Right after getting this positive screening question, to find out the cause of the gout, follow this. The mnemonic is D3HL plus psoriasis. D3 means diet, drug, and defect in kidney function. There are some diets which can cause gout, like sea product, then meat product. To rule it out, we just have to ask, what about your diet? Do you take enough sea product? To rule out the dietary causes of gout. The drugs causing gout for the PACES exam are the thiazide diuretics. It will be evident from the drug history. To rule out the CKD, we have to ask that what about the amount of your urine output? In CKD, there will be decreased urine output. And in CKD, there can be gout. So to rule out the defect in kidney function, we have to ask about the amount of urine output.
I have a question. What about
Sure.
can I ask waterwork or just urine output is better than waterworks?
Good question, doctor. Good question, doctor. Actually, what happens for the Indian surrogate, they don't know the term waterwork. They prefer the term urine output. This has happened for my case and also to many other candidates. I don't know the reason. I think you got sent at Delhi, right, doctor?
Yes, sir.
Okay, so please forget about waterwork. Mention urine output.
Okay, thank you so much.
Yeah, this has happened for multiple times. Whenever you ask for whatever waterwork, they will tell you what is waterwork. You can talk to many candidates. This has happened to many of them. Then H goes for the components of metabolic syndrome. That is history of high blood pressure, high blood sugar, high blood cholesterol, history of alcohol, history of smoking. That can cause gout. L goes for lymphoproliferative and myeloproliferative disorders. To rule out any type of malignancy in the PACES exam, just remember 3L. One L is loss of weight, another L is loss of appetite, another L is lumps and bumps in the body. So again, to rule out the lymphoproliferative and myeloproliferative disorder, just ask any loss of weight, any loss of appetite, any lumps and bumps in the body. your diagnosis is done. For psoriasis, just ask about any skin rash. So whenever anyone complains of knee pain and he had an episode of podograph, then directly go for the causes of gout in the form of D3HL. It is called DHL, DHL and psoriasis. You'll get your diagnosis in the PACES exam and also in the real life. So that's all for gout. May I know if there's any confusion up to now? Just to have a check back before proceeding on the rest of the part. Clear to all, doctors? Any question? Okay, Dr. Maya has given a thumbs up. What about other doctors?
Doctor,
Okay.
I have a question in previous chapter. Can I ask?
Sure, doctor. Please proceed on.
Sorry to ask them that time. You said
Okay.
that knee joint pain may be a different diagnosis of rheumatoid arthritis. But in case of rheumatoid arthritis, there should be a history of small joint pain in hand
Yeah,
joint.
there will be hand joint pain also. But for any symmetrical knee joint pain, it will be rheumatoid arthritis. Apart from knee joint pain, the patient can have symmetrical wrist pain, symmetrical pain of small joints of hand. All of them can be present, but it will be symmetrical. That's why you have to ask any other joint pain.
So sometimes it may happen without small joint pain, just symmetrical knee pain.
Yes. But
Okay,
it will
thank you
happen
so much.
symmetrical. Just by asking this question, he will give you all the answer. Whether it is affecting another knee joint, whether it is affecting wrist joints, he will give you the answer. So you don't have to think much. You don't have to ask them specifically that any small joint pain, any wrist pain, any elbow pain. No need to go for that hassle. Basis exam is not that much difficult that we used to think. I personally suffered a lot. But later I understood that this is something tricky exam and it is very much easy to pass the exam. Then for pseudo-gout, in the PACES exam, almost all of the time, it is due to secondary hemochromatosis. So we'll get the clue in the past medical history. In the past medical history, the patient will give you some blood disorder, history of blood disorder like hereditary spherocytosis or thalassemia. That's why he is taking repeated episodes of blood transfusion that is causing his joint pain, that is pseudo-gout. He can also develop CLD. So the screening question of pseudo-gout there will be no separate screening question. We have to depend on the past medical history for that. That do you have any past medical condition I should be aware of? He will give you that I have some kind of blood disorder. In the PACES exam, they usually don't give the full information that I have hereditary spherocytosis or thalassemia. He will just tell you that I have some blood disorder for which I take repeated blood transfusion. And you will get your diagnosis. This is some type of pseudo-gout. Okay. Then H goes for hemarthrosis.
আমি তো শিখছি না, আমি তো ক্লাস পাবো না। আমি কোন ক্লাসে করতে পারি না বাসায়, আজকে পাই গেছি, সুযোগ করে ফেলি। ভাত খাও আম্মা, আমি পরে আমি 12টা বাজে যাওয়ার সময়ও নেই ভাত খাওয়ার মতো। ডাইরেক্ট
there was a sound coming. Actually, please mute yourself, doctor. So hemarthrosis is another differential diagnosis. Can anyone guess where can we get hemarthrosis?
Hemophilia.
Yes, hemophilia, but it is not a PACES case, truly speaking. In the PACES exam, up to now, hemarthrosis case has not been given. I have not seen, but you can find some real life case in the real life. But it is not a PACES case. You will get the clue in the past medical history. Just ask any past medical condition I should be aware of. He will tell you that I have some blood disorder. You will get some positive family history also. So again, past medical history and family history is the savior. It has not come up to now in the PACES exam. Then O goes for osteoarthritis. This will be an old age patient who is having knee pain, heavy weight. So actually there is no screening question. Just by looking at the age of the patient and the mechanical nature of the knee pain, we have to guess the diagnosis of osteoarthritis. And you will feel the knee joint crepitation during examination. Is it clear to all? Then H goes for septic arthritis. For septic arthritis, you will get some history of fever. It will be given from outside as vitals, and there will be some component of entry route in the body. Let me give you an example. Let me show it from the real PACES case. Yeah. This was the PACES case. 65-year-old Mr. Watson has come with knee pain. From the outside, it was the vitals given. So look at the past medical history. He has history of osteoarthritis for last 3 years and a recent procedure in the form of intra-articular steroid injection was there 5 days back. And the highest recorded temperature was 101 degree. So unless you ask this thing, any recent procedure, he is not going to give you the answer of recent procedure. That is intra-articular steroid injection. That is causing the septic arthritis. May I know if this is clear, why I am showing this case to you? What is the importance of past medical history? Unless you ask for any recent procedure, the surrogate is not going to give you the answer. That recently, an steroid injection she took due to the previous episode of osteoarthritis. That is causing the septic arthritis for this patient. And last thing is trauma. You have to ask any history of injury. In the real life also, all the types of knee pain you can rule out by following this flowchart. So can I ask if there is any confusion, or have you got all the things up to now I have mentioned for knee pain?
Sir, can we distinguish gout and pseudogout clinically, sir?
In the pseudogout, there will be no visit of podogra. Were you present during the session? I discussed how to ask for podogra for gout. The question will be, any episodes of pain and swelling at gate toe? In the PACES exam, this history will be present. There will be history of podogra. Right now, the patient is having only knee pain, but if there is any history of podogra, then this is gout. And the pseudogout is usually given as secondary hemochromatosis. Just by looking at the patient, you will guess the diagnosis, because the patient will be probably a case of CLD and he is having some tanning of skin. Hyperpigmentation will be there. So in the gout, there will be history of podogra, but while in pseudogout, there will be no history of podogra. Again, for pseudogout, there will be something else in the past medical history. May I know, have you got your answer, doctor? I have forgotten the name who have given us the question.
Yes, sir. Clear, sir. And also the joint wise, I mean, mainly the knee joint will be involved in the pseudogout only.
Actually, gout can affect the knee joint, and pseudogout can also affect the knee joint. So the ruling out question is only the podogra and clues in the past medical history.
Okay, sir. Thank you, sir.
Most welcome, doctor. Again, for knee pain, never forget to check the gait to rule out the complications of knee pain from the physical examination. The examiner will clearly look at you whether you are offering to check the gait or not. If you check the gait in the form of triple CA, like ruling out the complication of knee pain, surely you will cover all the marks. So again, is there any confusion from the approach of knee pain from any of the doctors? If there is no confusion, please give me a thumbs up reaction, because this is going to be the last triple star scenario. The rest of the scenarios are double star and 1 star. Dr. Amit is clear, Dr. Maya is clear, Dr. Akanksha is clear. Dr. Farjana, any question? Dr. Farjana is clear. Dr. Lasita is clear. Yeah, all are clear. Thank you, doctor. The next prompt is ankle pain. This is the same approach as the knee pain. No else differential diagnosis. So the thing is, Odipara, liquor, any other joint pain, asking about morning jamming, look for whether it is more than 30 minutes or less than 30 minutes. If it is more than 30 minutes, it is seronegative spondyloarthritis. The differential diagnosis is the same as knee pain. And if it is less than 30 minutes, the differential diagnosis is mechanical ankle pain. The same differential diagnosis of knee pain. There is a cost. And at least offer to check the gait. Nothing else differential diagnosis is needed for ankle pain apart from knee pain. Knee pain and ankle pain, both are the same. Clear to all doctors? Any question or any confusion or any type of scenario you have experienced from the previous PACES cases scenarios? Okay, Dr. Nusrat is clear. Dr. Maya is clear. I hope all the things doctors are clear because it is all the same. The next prompt is shoulder pain. It is the next double step prompt. So whenever the shoulder pain prompt is given, we have to identify whether it is unilateral shoulder pain or bilateral shoulder pain. We have to ask, show me the site of the pain. If the patient shows you both the side, both the shoulder, then it is bilateral shoulder pain. If the patient shows you one of the shoulder, it is unilateral shoulder pain. They can again analyze the symptom using the mnemonic Udipara, Liquor, ask for any other joint pain, and based on the location, we have to formulate our differential diagnosis. In the PACES exam, for all the time, unilateral shoulder pain will be adhesive capsulitis. In the past medical history, can anyone guess what will you find in the past medical history of this adhesive capsulitis patient?
Diabetes.
Uncontrolled
Yes,
diabetes.
diabetes. Have you understood? You are getting the right diagnosis right now? In the past medical history, you will get a clue of diabetes and the patient is having unilateral shoulder pain. You just have to, in the differential diagnosis, you can just have to mention the other orthopedic causes of unilateral shoulder pain. They are just supraspinous tendinitis or osteoarthritis. These are orthopedic related causes of unilateral shoulder pain. These are not medical causes. The medical cause is only adhesive capsulitis. And unilateral shoulder pain in the PACES exam, all the time, it will be adhesive capsulitis or frozen shoulder. What examinations you have to do for adhesive capsulitis? For the given case, you will get it in the physical examination video. I have described it. For bilateral shoulder pain, in the PACES exam, there are three differential diagnoses. One is polymyalgia rheumatica, another is polymyositis and dermatomyositis, third is fibromyalgia. All the cases has come in the PACES exam. In polymyalgia rheumatica, there will be proximal stiffness present, but no weakness will be present there. That is, morning jamming will be present. In polymyositis and dermatomyositis, there will be weakness, but no stiffness. And in fibromyalgia, there will be poor sleep. All of the cases has come in the PACES exam. So what can be the differential screening question? In polymyalgia rheumatica, we have to ask about morning jamming. Okay, so can I ask me, are you hearing any background noise from my side? Is it become difficult to hear from my side? Because from outside, I'm having a lot of noise here due to the World Cup final.
No, sound is okay.
Okay, and pleased to hear that. I'm hearing a lot of noise here. Okay. In polymyalgia rheumatica, there will be proximal stiffness. So how can we ask the question? Ask the screening question: do you have any morning jamming of your shoulders? And there will be no weakness. In polymyositis, there will be weakness. So we can ask any difficulty in coming here or getting up from the chair. For fibromyalgia, we can ask, what about your sleep? In fibromyalgia, there will be diffuse body pain apart from shoulder pain, and the patient will have some unrefreshing sleep, and there will be a component of anxiety in the history. So that's all for bilateral shoulder pain. Can anyone tell me, if you get a case of polymyalgia rheumatica, what other associated disease you need to rule out?
Giant arthritis.
Yes, doctor, giant cell arteritis. And in the PACES exam, if anytime giant cell arteritis case is given, all the time you will get polymyalgia rheumatica, according to my experience. So every time GCA comes with polymyalgia rheumatica. So look for that. And for bilateral shoulder pain in the PACES exam, these are the three differential diagnoses. And that's all for shoulder pain. Any question or confusion? All the cases that has come in the PACES exam for shoulder pain, you will get it in musculoskeletal case notes. You have to make the notes for physical examination, investigation, and management for that. Is it clear to all? If it is clear, again, give me a thumbs up reaction so that I can proceed with the next problem, that is hip pain. Dr. Amit is clear, Dr. Akankar, Dr. Maya, Dr. Nusrat, Dr. Tejas. Are we having any confusion, doctor? Okay, Dr. Gulzar, I'm not hearing anything from your side, doctor. Are you having any confusion or any type of thing? Okay, let's proceed to the next prompt. The next prompt is hip pain. In the PACES exam, usually hip pain is given in the Indian subcontinent with a background of steroid use. So again, we have to analyze the symptom using the mnemonic Odipara and Liquor. Then the differential diagnosis will be, the most important differential diagnosis is avascular necrosis. Second DD we can keep in the mind is osteomyelitis. And this is important for the Middle East centers. In the Middle East, there is sickle cell disease. So any sickle cell disease patient who is having loose motion, that loose motion can cause dehydration, causing avascular necrosis. Again, loose motion due to salmonella diarrhea can cause avascular osteomyelitis of the hip joint. But for the Indian subcontinent, these will be avascular necrosis of the hip joint. The causative agent will be either steroid use or alcohol use or sickle cell disease. What happens in the PACES exam, actually, they try to switch the cases. Like at one carousel, the case was given at short case station. At another carousel with another day, they will switch the short case station with a long clinical consultation. Let me give an example. Suppose in the first day, first carousel, a candidate has got a case of renal transplant in the abdomen station. But the same case can be given at the next day with a long clinical consultation. And that time the prompt will be hip pain. Can you guess why the hip pain is there? Any doctor? Sorry? Yes, Dr. Nusrat, what do you mention? I'm again mentioning first day, first carousel. A candidate has got a case of renal transplant in abdominal case. But the next day, another carousel, the same patient has been given to you and given to another candidate with the prompt of hip pain. So what is the cause of that hip pain?
Steroids.
Maybe
Yes.
steroid overuse, avascular necrosis.
Not overuse. Even simple use of steroid can cause avascular necrosis. So that is why whenever you are going to appear at exam, try to collect all the cases from the beginning. Like first carousel, what cases has come? Because same case can be given to you with different prompt, even from the short cases. Like aortic stenosis is a very much popular prompt in the short case, short cardiovascular station. The same patient will be given at next day with a prompt of syncope or collapse. This happens for many times. In abdomen, you will get a case of CLD. CLD is a most common prompt case, most common case in short case. And another carousel, the same patient will be given with the prompt of blood vomiting. So you have to try to identify how the cases can come in the PACES exam. Then it will become easier for you to crack the exam. So this is all the things we have to know for hip pain and what examinations we have to do for hip pain. I have described this in physical examination video. One thing is that in avascular necrosis, internal rotation of the hip joint is impaired. In the PACES exam, you will never be given any real avascular necrosis patient. But you have to check the internal rotation of the hip joint. It is being checked by making the knee joint 90 degree and making internal rotation of the hip. Then the patient in the PACES exam might not complain of any hip pain. Whether in real life, any avascular necrosis patient will complain of hip pain. But in the PACES exam, the patient might not complain of any hip pain whenever you do the internal rotation of the hip joint. But don't be frustrated because this is not a real patient. Sometimes the patient will be instructed to say that he is feeling pain whenever you are doing the internal rotation. But this will not happen for most of the time. So that's why you have to depend on the history a lot. In the PACES exam, they will not provide any real case for hip pain, any avascular necrosis. This type of unstable cases are not given in the PACES exam to ensure the patient's safety. I hope all of the doctors have got my point. Is it clear to all doctors? Why history taking is very much important? Okay. So the next prompt, we have only 2 prompts left. The next prompt is neck pain. It is 1-star prompt. It has come only one time with the diagnosis of ankylosing spondylitis. I have never seen any time with this neck pain prompt. The thing is very much similar, simple. We have to analyze the symptom using the mnemonic Odipara, then liquor, then any other joint pain, then ask for morning jamming. If the morning jamming is present, the differential diagnoses are only 5. One is seronegative spondyloarthritis, that's ankylosing spondylitis, psoriatic arthritis, then enteropathic arthritis and reactive arthritis, and this rheumatoid arthritis. These are the 5 differential diagnoses. But it came only one time in the PACES exam with the diagnosis of ankylosing spondylitis. What will be the screening question for each? Already I have discussed them in detail. And if there is no morning jamming present, it can be cervical spondylosis, cervical radiculopathy, or cervical myeloradiculopathy. But this has not come in the PACES exam up to now. So you can just make it remember in case the patient examiner asks you in the cross question that what are the non-inflammatory causes of neck pain, then you can mention these 3 causes, that cervical spondylosis, radiculopathy, myeloradiculopathy. Otherwise, it is not important because it came only one time with ankylosing spondylitis. And ankylosing spondylitis is a very much important case for PACES exam. You will get a detailed sequences of examinations, what to do. Okay, let me show you. Please give me a reminder if you did not get this folder. Sorry, this is thyroid sequence. Yeah. For any type of seronegative spondylitis, to confirm the diagnosis, in the physical examination, you have to check lumbar movement in 4 plane. You have to check the neck movement in 6 plane. Then you have to check for kyphosis. You have to check for occiput wall test and heel wall distance. You have to measure it with measuring tape. And you have to offer to do modified Schubert test. In exam, you will have to do this. I had to do this. My case was low back pain. It was ankylosing spondylitis. And I had to do the modified Schubert test with a marker. Then to find out the cause, check the psoriatic skin rash, look for mouth sore for Crohn's disease, and offer for part actor examination to rule out the perianal tag. Look for eye redness and rash at sole, that is keratoderma blennorrhagica, that you will never get in the PACES exam, but you have to do the acting of checking that and offer to check rash in private part, that is Sarsen valleritis. And look for complication 6A. The 6A is first A, anterior uveitis. Check for eye redness and pain. Second A is apical fibrosis. Just auscultate the apex of the lung. Third A is ankylosis of the costochondral and costovertebral joint. Just put your hand over the chest and tell the patient, take a deep breath in and out. Look for chest expansion. Check for aortic regurgitation. First, check for collapsing pulse and aortic regurgitant murmur in the left fourth intercostal space in breath holding after expiration. It is just an acting. You are showing the examiner that you know aortic regurgitation can happen in case of ankylosing spondylitis. Then to rule out amyloidosis, just offer urine dipstick because amyloidosis can cause nephrotic syndrome that can cause proteinuria. At last, press on the back of the heel to rule out Achilles tendinitis. So these are the physical examination sequences of ankylosing spondylitis. Also in the physical examination video, I have explained for each case separately. But this thing has been built based on the request of the candidates. Again, I'm requesting if you need any such type of flowchart or written sequences for any type of disease or any type of prompt, please inform me. I will make that thing for you. And all of you will get access to these sheets that has been produced based on the request.
Sir, I had a doubt.
Yes, doctor?
So when we are doing the examination, then do we have to present our findings alongside while doing it, or
No, not needed.
okay, sir.
But whenever you are doing the examinations, do some acting.
And do
Suppose
we have to say why we are doing one
no,
examination?
it is not needed actually, because sometimes it is not needed at all. But whenever you are getting any positive physical findings, do some body gesture and facial expression in such a way that the examiner can understand that you have got this finding. Let me give you some example. In case of systemic sclerosis patient, there are lots of positive physical findings like skin tightening, Raynaud's, then sclerodactyly, calcinosis. So whenever you are going to present your case, you are going to encounter with the patient examiner in the form of 4 questions. After you are done with your 15 minutes, the examiner is going to ask you, do you have any diagnosis or differential diagnosis? Then the next question is what are your positive physical findings? So whenever you are going to present the positive physical findings, sometimes you might forget important positive physical findings, such as for lots of findings, such as for systemic sclerosis. For that type of patient, my suggestion is whenever you are doing the examinations, do some body gesture, do some head nodding and facial expression in such a way that whenever you are getting any positive findings, you are giving an like non-verbal signal to the examiner that you have got this. This will help you because suppose you have got some calcinosis at the hand, then with your finger, look at carefully and do some indication that you are happy to get that. The examiner will keep this in the mind. And whenever you are going to present your case, even if you forget to mention the calcinosis, the examiner is going to tell you, you did check something in the hand. What was that?
Yes, sir. Thank you, sir.
So this is why you have to know how to do the acting. You have to present yourself as smart candidate. Do a smiley face, do some greetings, even with the examiner. And these will be positive for you. So any other question from any of the doctors regarding the neck pain? If there is no confusion, then let's proceed to the last prompt. Last prompt is diffuse body pain. It came one time with the prompt of muscle cramp. And another time it came with, sorry, not multiple joint pain. It is diffuse body pain or muscle cramp. Both can become. Again, we have to analyze the symptom using the mnemonic, Odipara and liquor. Let me drink a glass of water. Okay. After analyzing the symptom, Odipara and liquor, the differential diagnosis that we have to consider for the PACES exam are mentioned here. Apart from this differential diagnosis, in real life, you may see a lot of other differential diagnoses. Like in real life, I have seen a patient with hypothyroidism coming with diffuse body pain. But I can make you guarantee that hypothyroidism case will never be given in the PACES exam with the prompt of diffuse body pain. In real life, you can get it, but not in the PACES exam. And these are the differential diagnosis that comes in the PACES exam with the prompt of diffuse body pain or muscle cramp. They are dermatomyositis or polymyositis, rhabdomyolysis. This rhabdomyolysis can be drug-induced or exercise-induced. It can be viral myalgia, osteomalacia, polymyalgia rheumatica, and fibromyalgia. So what will be the screening question for each? For dermatomyositis and polymyositis, we have to ask the question of proximal weakness. That do you feel difficulty in combing hair or getting up from the chair? For rhabdomyolysis, we have to ask urine output. What is the amount and color of your urine output? And this is the most important differential diagnosis that we have to rule out for each type of diffuse body pain, whether the patient is developing rhabdomyolysis. Because in rhabdomyolysis, patient can have acute kidney injury, also high color urine due to myoglobinuria. So that's why we have to ask the question of amount and color of urine output. Again, I'm mentioning it is important to rule out for all type of diffuse body pain. Okay, I'll give you some example because important safety netting is there. For viral myalgia, we have to ask any sore throat. For osteomalacia, we have to ask again any difficulty in combing hair or getting up from the chair. It is due to proximal weakness because in osteomalacia, patient can have proximal weakness apart from diffuse body pain. And there will be some component in the past medical history, like patient can have some celiac disease, or he can have past medical history of cystic fibrosis. Some clue will be there for must. Then polymyalgia rheumatica, we have to ask the question of proximal stiffness. That do you feel any morning jabbing at your shoulder? And for fibromyalgia, can anyone guess what is the question? Can anyone remember?
Refreshing sleep.
Yes.
Unrefreshing.
Any unrefreshing sleep for fibromyalgia. And that's all for diffuse body pain differential diagnosis. Let me give an example. It is a real PACES case. You'll get this case in the PDF case sheet. It was probably a 40 years old female, sorry, not 40, it was probably 50 years old male. Has come with diffuse body pain. The pain is all over the body. And in the drug history, he's taking atorvastatin.
Rhabdomyolysis.
Let me tell you, in the dark history, he's taking atorvastatin, and recently he is taking NSAID because recently he has taken part in a marathon where he had a lot of sweating, and after this sweating, he is feeling severe pain in the body. To combat with that pain, he has started taking NSAID. So, what is your differential diagnosis and what important safety netting you have to? He is also mentioning that his water work, his urine is getting high color and amount is reduced. Yeah, rhabdomyolysis is due to
Due to AKI.
Heavy exercise.
sorry, sorry.
Heavy exercise.
Yeah.
Statin drug.
Statin toxins.
Yes. There's statin drug, exercise induced.
Yeah, and the runner marathon runner.
Yes. Exercise induced or statin induced. Both can be that causative engine. But what important safety netting you have to mention? Without uttering this thing, you will not secure full mark in clinical judgment.
Stop the medication.
Which one?
NSAIDs.
Yes, you have to stop both the medication, particularly NSAID. If you don't utter to stop NSAID or painkiller, surely the mark will be cut. And what happens in the PACES exam? Sometimes the examiner write it beforehand in this mark sheet. What things they expect. You just have to utter the word and they will just keep a tick mark beside the causative findings, beside the expected findings. Like you have mentioned to stop the NSAID, he will just give a tick mark that stop NSAID, and he will give you the full mark after him. Once you get the feedback, you'll see it. So that's all for diffuse body pain or muscle cramp. May I know if it is clear to all. Any confusion or any question? Dr. Farjana is clear? Please, doctor, feel free to ask me any question. What about other doctors? Dr. Rita, are you having any question or confusion?
No. Okay.
Okay. Dr. Akanksha is also clear. Okay. I think all the doctors are clear. So this is the diffuse body pain. There is one problem left. This is multiple joint pain. It has come only one time. And sorry, what is this? And the cause was SLE. So the multiple joint pain was inflammatory in nature. It has come only one time in Dhaka Center. The prompt was multiple joint pain. Right after entering the station, the patient was telling, it was a female, she was having pain at small joints. And she was telling that I'm having morning jamming. So you can approach for this hand pain joint prompt like the same. The patient is complaining with joint pain. So you can ask any skin rash, any rash in the mouth after going to the sun. You will get your diagnosis. This case is come at one time at Dhaka Center. And she was also having a renal abnormality in the form of frothiness of urine. Any type of connective tissue disease, we have to rule out kidney involvement. That's why in the given flowchart, you'll find this thing, that connective tissue screening question. Any change in urine about the amount, color, frequency, and frothiness. This case came at Dhaka Center. Prompt was multiple joint pain, diagnosis was SLE, and she was also having frothiness of the urine. And that's all for this case, this session. So these 9 prompts I have discussed. Up to now, in the last 4 years, these 9 prompts has come from the musculoskeletal system. And once you know how to approach for each given prompt, any type of case given in the PACES exam, you will surely be able to crack it. So from now on, what will be your task? I will post the recording at the YouTube. This is the free session. So, and the dashboard is actually on the way to be prepared. Once it is prepared, all the recordings will be uploaded there. So you have to make your notes for the specific prompt, like what things I have mentioned for the hand pain, for the joint pain, all the things. You have to make this note line by line. So take a personal notepad for you and make notes only for the prompt session first. Then pick up the PDF case notes. Like, let me pick up a case. Like, this is the first case. This is actually my case at Bangalore. First time. It was prompt was hand pain. It was a joint pain. The patient was not able to speak in English properly, and there was no surrogate. Okay, so what you have to do, you will pick up the PDF case sheet. There will be some blank page after each case. At the first page, you have to make the notes of physical examination for this case. At the next page, you have to make notes of investigation and management. After that, you will find another blank page, which will be there. Like in the future, if you want to add any other information important for this particular case, you can take the notes there. But you have to complete the physical examination sequences and the investigation and the management by taking help from the access to the drive link for each of the given case from this recording. This case is 45-year-old Mr. Jackson has come with hand pain. So first in the physical examination, we have to divide it into 3 sections. To confirm the diagnosis, to find out the cause, to find out the complication, and looking for association. So in this recording, I have explained in detail what you have to write for physical examination, what you have to look for physical examination, then for the investigation and management. So you have to make your own notes for that. Once you are done with making the notes, there are 33 cases. Sorry. You will find an index that will given PDF case notes, and there are 33 cases from this musculoskeletal problems. That is case number 1 to case number 33. So up to the next practice session, your task will be, after making the notes, you have to start practicing mutually using this mark sheet. I will suggest you to take 11 minutes in total during practicing online. It is not needed to practice face-to-face. In the online, you have to practice with each other. You just have to throw the one case to each candidate and see how he performs. And this will be done mutually. One time you, another time your partner. And you have to try to provide marks based on each case, each skill. I will help you. Don't worry. If you face any kind of problem regarding judgment, I will help you. Initially, you will face a lot of problem regarding providing judgment. But believe me, if you can follow this pattern, just after 4 sessions of practice, you'll see that you have almost become a close to the mentor, and you don't have to depend on anyone else for the feedback. You will be your own mentor. And this is very much essential for this case, that I want every one of you to be like the long clinical consultation mentor. And also in the next practice session, I will not do the judgment for myself. What I will do, I will make a pair. Like for the next session, suppose Dr. Anika is there, and any other doctor, let me see.
Yes.
Yeah, Dr. Anika and Dr. Maya. Suppose 2
Yes.
doctors are there. So what I will do, I will give a case exactly from the given homework to Dr. Anika, and I will request Dr. Maya to give the feedback. I will act the surrogate, and after performance of Dr. Maya, after performance of Dr. Anika, Dr. Maya will give the feedback based on each skill. Of course, I will help her. If she makes any mistakes in providing the skills, providing the judgment of the skills, I will make her correct. But I will not do all the things myself, because I don't want you to remain dependent on myself. Then the same thing will happen to Dr. Anika. Dr. Maya will perform later hand, and Dr. Anika has to provide the judgment, and I will help her. Is it clear? Dr. Tejas has asked, registration window be open. Actually, doctor, for type 1, the slots are limited. So once it is fill up for 10 candidates at each batch, it is done. I cannot make it open because it is not possible to take more than 10 candidates. For each pair of candidates, it takes 1 hour to do the whole practice session. And it takes at least 5 hours to complete the 10 active candidates. So may I know if anyone has any kind of confusion regarding what you have to do right after today? Any doctors? Anything else you want to know? Okay. If there is no confusion left, then let's say bye-bye for today. And our practice session of this musculoskeletal prompt will happen from next week. You will get 1 week to take preparation. For LCC batch 12, the practice session will be on next week's Monday. And for LCC batch 13, the practice session will be Tuesday next week. And at the Sunday, we'll meet again with the GIT prompts. We'll discuss the approach to GIT prompts at the Sunday. Okay, doctor, thank you all. And let's see how you can go through the homeworks. And please feel free to ask me any type of question. If you face any type of confusion whenever you are going through making the notes and homeworks. Thank you, and take care, and enjoy the World Cup final.
Thank
Goodbye.
you.
Most welcome, doctor. Thank you.